Good evening, everyone. So, everyone who can listen to me, just give me a thumbs up, guys, so that I can just start with the session. Yes, so I'm just waiting. So, everyone who's around, yeah. So, Dr. Raj, all good, all good, all good, Dr. Raj. So, am I visible and audible properly? Yes. So, Dr. Abhishek, Dr. राज बोल रहे हैं हेलो सर मुझे डॉक्टर बनना है हाँ तो उसके लिए एमबीबीएस पढ़ना पड़ेगा डॉक्टर अभिषेक सेज यस सर somehow the other in between I'm getting the chats. I'm not getting the complete chat. Just give me a second so that I can just refresh. uh, there we go. Right. Okay, so we'll go ahead. Well, Dr. Abhishek, other people just give me a thumbs up so that we can start with the session. Right, so only Dr. Abhishek has given me a thumbs up. So we anyways we'll continue with the discussion here. We'll go ahead and discuss with the INI-CET. Acha, Dr. Raj says I'm doing MBBS. Okay, ठीक है Dr. Raj, great. Anyways, this point, our discussion today is INI-CET's short part of the complete series. So what we are going to discuss, guys, today is basically all the INI-CET questions which have been come, right? All the INI-CET questions which have been there. So maybe, ठीक है, जो भी यार questions तुम लोग, I'll ask you the question, उसके बाद फिर answer करना यार, guys, all of you. ठीक है, so anyways, we are going to discuss anesthesia. My name is Dr. Vinish Srivastav and Dr. Abhishek, I think you are there. Other people, I don't know. मेरे को बाकी लोग दिख नहीं रहे अभी. So thumbs up from everyone. Dr. Abhishek has given a thumbs up. Anyone else, just give me a thumbs up so that I can go forward. Yes, Dr. Abhishek, other guys. So without wasting any more time, because I wanted it to be an interactive session. I want this to be an interactive session. So that is the reason I wanted you guys to give me answers and then we can go forward with that. So all the last 4-5 times questions is what I've included. Yeah, Dr. Nithya is also there. Okay, fine. So let's start and please answer and then accordingly we'll take a call. So this is the first question. Normally I have all the questions included here which have been asked right from 2020 November to 2022 November, right? 2022 November. So these 5 sets of questions, we have most of the questions covered and we'll discuss them as a part of rapid revision that we are doing as fast as we can. So please mark your answers or let me know. Where is inhaled nitric oxide used? A. Anesthesia. B. Malignant hyperthermia. C. B. Malignant hypertension. Malignant hyperthermia. Pulmonary hypertension. Right, guys? So just give me answers so that I'll discuss fast and then we'll go. There are almost 30 questions, I think, that we'll discuss. 20 to 30. We'll try to finish them as fast as we can so that your time is also not getting wasted. चलो यार जल्दी जल्दी. Anyone? What's the answer? Inhaled nitric oxide. Where is it used? Dr. Nithya says D. Absolutely correct. Absolutely correct, right? So this was a kind of confusing question which was asked because normally what would happen, why this is important, because instead of reading nitric oxide, you might just read it as nitrous oxide. And if you read it as nitrous oxide, you will start thinking it is in anesthesia, right? Simple question, nitric oxide, inhaled nitric oxide is used for pulmonary hypertension and malignant hypertension is not the answer. Malignant hyperthermia is not the answer, right? So it is not used for anesthesia. For anesthesia, what is used is nitrous oxide, not nitric oxide. So nitric oxide is basically used for pulmonary hypertension. Just 2 words about it. So inhaled nitric oxide basically is used as a pulmonary vasodilator. So inhaled pulmonary vasodilators Apart from nitrous oxide, you've got other things also. All of you have studied in medicine. So these are all prostacyclin or its analogs also, milnirone. All these drugs are there. Point is, what are the uses of these inhaled pulmonary vasodilators? Primary hypertension, primary hypertension. That's one of the things. Cardiothoracic surgery, ECMO. Lots of things are there. Transplantation, ARDS, hypoxemic failure. So the point is here, the question which is asked is primary pulmonary hypertension. This was the thing asked in the exam also. Right? Let's go to the next question without wasting any time. Which amongst the following anesthetic gases will be associated with the blue pipeline in the operation theater? Right? So these are all INI-CET questions. All of them are INI-CET questions. They are all a revision that we are doing. All of them. All the questions. Okay? You'll find them to have appeared sometime or the other from the time INI-CET has been there. Waiting for your answers, guys. So, simple question here. This is a simple one though. Try to refresh also. Anyways, if I'm not getting answer, let me just give the answer. Here, the correct answer is nitrous oxide, right? So when they are asking about blue, okay, Dr. Nitya's answer has come right now. I didn't see it before. So blue pipeline is nitrous oxide. Okay. Remember, these color coding become very important right from cylinders as well as pipelines. Even the inhalational agents, we'll just see them in short. Air is always in terms of pipeline black in color. Nitrous oxide is always blue in color. Vacuum is always yellow in color. Oxygen is always white in color, right? So this holds true when we are speaking of pipelines, right? This is true about pipelines. Now, the same thing when they are in cylinders, the color is slightly different, right? So these are the various cylinder colors that you will find. So here you will find that oxygen is this one, which is black body with white shoulder, right? This is oxygen, and the pin index of oxygen is 2.5. Important point, right? Air, you will find this as gray in color, so gray body and white shoulder. Gray body and white shoulder. Pin index is 1.5. This is nitrous oxide, completely blue in color. The pin index is 3.5. Okay. Then you find Antonox, which is a combination of oxygen and nitrous. So you will find it as blue in color and white shoulder. ये उसका white shoulder है. And the pin index number is 7. This is carbon dioxide. Okay. So carbon dioxide is gray in color, right? And the pin index number is 1.6 or 2.6. So this cylinder, the first one that you have seen, no, the second one, this is air, this is oxygen, this is nitrous oxide, this is Antonox, right? This is carbon dioxide. So these are the various cylinders. This brown color that you see is helium or heliox. Helium or heliox. Again, the pin index number will be 2.4 or 4.6. Not very important, but yes, before that, all the 5 are important. Thumbs up, everyone. Is that okay? So we discussed the pipeline colors with you. These were the pipeline colors. These are the cylinder colors apart from the pin index numbers, right? And I also like to add that please remember the colors of the what you call inhalational agents. So when we speak of halothane, that is also color coded. Halothane is red in color. Enflurane, it is orange in color. Okay. Isoflurane, it is purple in color. Desflurane, this is light blue in color, or maybe you can just write it as blue. And you have sevoflurane, yellow in color. So pipelines, guys, are spread all over the hospital. You can see the colors. So this is the black one, air, vacuum, nitrous, oxygen. And they normally come and get attached to the anesthesia machine at the back. They are spread all over the hospital, right? So these are the pipelines which get attached to the anesthesia machine, and they become as a part of the intermediate pressure system. Thumbs up, everyone. Point clear. May I move forward? Thumbs up, guys. May I move forward? So let's take the next question. Okay. Now, Please remember, these are the two simple questions that I asked before. In INI-CET, what we have observed, I mean, from when I went through all the questions and the way things were there, remember they have paid a lot of attention to oxygen delivery devices, oxygen delivery to a patient. They have also paid a lot of attention to ventilator and airway management and CPR. Airway management and CPR. This has been the most important points where they have concentrated. And if you will see, even in NEET PG, this time around when they asked you, the question was regarding CPR, airway management, and sort of oxygen delivery. If you see this time also, NEET PG as well. So you find the same thing is being done for NEET PG, and the same thing is for INI-CET. And what I would like to say, even monitors are there, but somehow the other they have asked less questions from Pharmac in the last 1 year. Pharmac questions have been less. Pharmac of anesthesia drugs they have asked less. They have concentrated more on oxygen delivery devices, ventilator, airway management, CPR. You have and monitors. So please understand, do not miss these points. Pay attention to them, even if you're preparing for FMGE, NEET PG, or INI-CET. Anyways, INI-CET is what we are discussing out. So let's go forward. Next question. What is the, please read the question properly. A small change can change the answer. Okay, so a maximum oxygen flow rate through a conventional oxygen device. Okay, so please tell me the answer. A, B, C, or D. Yes, guys, only Dr. Nithya is giving me the answer. Other people are also there. I can see other people also joined in, but no one has given me the answer apart from Dr. Nithya. Dr. Abhishek was also there. Haji, किसी के आंसर्स नहीं आ रहे. So I'm waiting for the chat, Sarah. Not getting anyone's reply. Yes, guys. Dr. Akhil has given me an answer, right? Dr. Akhil. Dr. Akhil says D. Okay. So what we are discussing is a conventional oxygen device, right? Okay. Dr. Nithya says C. Dr. Nithya. Okay, wait. Conventional. So please remember one thing. Okay, let's take another question, then I'll discuss this. Okay, so maximum, just remember maximum oxygen flow rate. I think there's a confusion that you have mentioned between C and D. Dr. Nithya has said C, Dr. Akhil has said D, right? These are the options we have now. Let me change this question slightly and now take it further, and then I'll discuss the difference between them. Now I've changed one word, right? And the word change is telling us what is the maximum oxygen flow rate through a conventional oxygen therapy when you're doing a conventional oxygen therapy. All right. So anyone, what is the answer for this? Yes. So Dr. Nithya, Dr. Akhil. Waiting for the answers. As I said, I like to keep it interactive so that all of us So Dr. Nithya has said, now there's a difference of just one word, and the difference of the word between the questions is that conventional oxygen device and conventional oxygen therapy. So now remember, when you say a conventional oxygen device, guys, so a conventional oxygen device is normally a face mask which you use, and a face mask works normally between 5 to 10 liters, normal conventional oxygen device. Okay, so here the answer would not be 15 liters because the normal face mask or the Hudson mask works between 5 to 10 liters. So the maximum oxygen flow rate if it is a conventional oxygen device and we are assuming it is the face mask, would be 10 liters. But there are different types of face mask, and one of them is non-rebreathing mask as well. So that can use different amount of oxygen, right? So that there is where you can use 15 liters. So therefore, as I think Dr. Nithya has said, here is where you will get the answer for conventional oxygen therapy as C, 15 liters. If it's a conventional oxygen device, I would stick around with 10 liters because I will expect it to be a face mask. But if I'm expecting it to be a non-rebreathing mask, in that case, I can go up to 15 liters. And that is the difference. Thumbs up, everyone. Is this point clear? That's according to me. There are a lot of controversial questions in INI-CET. Most of them are all controversial. Okay, there can be multiple answers to them and multiple books have given different things, but I'm just telling you the way I would go with them. Okay, based on my knowledge. No one is perfect, let me tell you that as well. So thumbs up, everyone. Dr. Akhil has said D here. Dr. Akhil, यहाँ पे भी वही point था ना, C. 15 liters is the answer. Dr. Nithya has given me a thumbs up. Let me go forward. Now, based on the same thing, let's take another question. I've changed this slightly from what was given in the INI-CET. 55-year-old patient presents to emergency with history of high-grade fever, cough and headache since 3 days. It's a clinical scenario. Chest X-ray picture shows signs of ARDS. On examination, the respiratory rate is 30. SpO2 shows 89%. Which of the following devices will be least useful in this patient? Please read the question properly. Dr. Akhil, I'm going to discuss all the oxygen delivery devices once I'm done with these 3 questions. So don't worry, we'll discuss all the maximum flow rates as well as how much it is going to go. But let me finish off these 3-4 questions which are asked from the same thing. Okay. Right? Answer guys, jaldi. What's the answer here? Jaldi means fast. So according to you, which one is the least useful? We know this is a patient of ARDS, right? The respiratory rate is 30. The SpO2 is showing 89%, right? I waited for a while. मेरे को answers अभी आए नहीं. I think you people must have typed it, but I haven't got it as yet. Like I'm waiting for the answers on my phone. Okay. So let me give the answer here. Okay, the correct answer here would be, in that case, C, the nasal cannula. Okay, nasal cannula. Dr. Akhil says B and D. B and D nahi na. Least useful. देखो, least useful means which of the ones will not be useful. High flow nasal cannula, will it be useful? Yes. Non-invasive ventilation क्या होता है? Non-invasive ventilation is your BiPAP or your CPAP. Will it be useful in a patient like this? Yes, it will be useful. Invasive ventilation, will it be useful? Intubation. If the patient is in ARDS, of course it will be useful, right? But of course it's not the first choice. I'm not saying invasive ventilation and intubation is your first choice. But if the patient is ARDS, you might have to do it ultimately, right? Similarly, BiPAP and CPAP can be used in the patient. Similarly, high flow nasal cannula can be used in the patient. But nasal cannula, guys, it provides only maximum 44% oxygen. It works only between 1 to 6 liters. Nasal cannula is a small nasal prongs that you get, which is placed inside the nostril, and therefore out of all the devices, the least useful that you will see is the nasal cannula. Okay, it is the least useful out of all of them. Hopefully you've understood this, right? Again, a slight change, and as I said, I'm going to discuss all these oxygen delivery devices after this question, which is come from here, right? So 55-year-old COVID-19 patient admitted in COVID ward, right? Respiratory distress is there. SpO2 is showing 88%, right? The patient has been administered oxygen by simple face mask. Flow rate is 10 liters per minute. Okay. After an hour, this SpO2 is 89%, which according to you is the next best step in the management of this patient. Okay, so options are high flow nasal cannula, increase oxygen flow, endotracheal intubation, no additional intervention. Dr. Nithya has said B, right? And anyone? Dr. Akhil, what about you? And Dr. Abhishek was also there. Okay, guys, before I end the session today, it will be about an hour and a half too. Please let me know that I will have to save the whatever I'm writing down. Okay, so annotation that will be available on the Telegram group. Okay, so please remind me to save what I'm writing. Dr. Nithya, Dr. Akhil, both have said B. But guys, okay, okay. According to me, it should not be B, it will be A. High flow nasal cannula. As I told you right from the answer before also, high flow nasal cannula is useful. Now, if you see in this patient, for 1 hour, this patient is in respiratory distress. They have given COVID-19 patient. Remember, COVID has come back again. And COVID may, the biggest problem is if you intubate a patient, the patient is almost gone. So invasive procedures normally are not done in COVID patients. We try to avoid it as much as possible. So this endotracheal intubation is out. The patient is in respiratory distress and saturation is 88. So at 88, if he's in respiratory distress, we have given him a normal simple face mask which works at 10 liters per minute. It's not a rebreathing mask. Had it been a rebreathing mask, that can be made 15 liters per minute. I just told you a while back, simple face masks normally works between 5 to 10 liters, right? It provides 60% oxygen at the maximum at 10 liters. At 15 liters, it's not going to increase it so much. Okay. So in this case, if you increase to 15, your percentage of oxygen is not increasing. So basically, I will prefer to use the high flow nasal cannula. According to me, this has to be the correct answer. Thumbs up. Is this point clear? So increasing the flow rate to 15 here will not make a difference. It's a simple face mask. It's not another type of face mask. Okay. Here it's the maximum 10 liters you've kept. It will work only with that. All right. Endotracheal intubation ideally will avoid in a patient like this. Of course, because he's not improving and 88 it has become 89. So you need to intervene. This question is also out option. The two options which were there out of them, I will stick with high flow nasal cannula because high flow nasal cannula can provide almost 100% oxygen. It's a high flow device, right? 100%, almost 90 to 100% oxygen. The maximum oxygen that you will get from a simple face mask is 60%. I'm going to discuss this with you right now. Okay. Hopefully this point is clear and the way that we thought about it, right? Last, before I discuss all the devices, can you see in the last 5 papers, they have asked you almost 5 or 6 questions from oxygen delivery devices. This is another one. Maximum FiO2 is delivered by which of the following devices? Yes, guys. Venturi mask, non-rebreathing mask, Hudson mask, or nasal cannula. This is again the same INI-CET question, INI-CET question which has been asked. Yes, guys. कौन आंसर देगा? Dr. Nithya has given the answer, right? Dr. Nithya has said A. Venturi mask, says Dr. Nithya. Yes, Dr. Akhil, what about you and Dr. Abhishek? दूसरी जो लोग थे वहां पे. So let me give the answer then. Dr. Nithya has said A. Dr. Nithya, now I'll discuss all the oxygen delivery devices. The correct answer is not Venturi mask here. It is non-rebreathing mask. Okay. So can you see all these questions are different, but you just need to have your points clear as to what will give maximum. Not Hudson mask, not nasal cannula, not Venturi mask. So when we are speaking of oxygen delivery devices, guys, let me do one thing. So, and please ask me to save in the end what I'm writing. Oxygen delivery devices, guys, can be classified into 2 types. I'm just discussing this point out because I think it is important. And they can be classified into 2 types. One is low flow devices and other is high flow devices. Low flow devices would be the nasal cannula or the nasal prongs that I was discussing about. The two, the one that go into the nostrils, right? And nasal prongs normally work between 1 to 6 liters of flow rate of oxygen, giving a maximum of 44%. Then there is something called as the simple face mask or the Hudson mask. The Hudson mask is the same thing for the simple face mask. You also call it as the Hudson mask. Right? Hudson mask works between 5 to 10 liters and it gives a maximum of 60% oxygen. Right? Then it is 60% is too less for emergency. So they have something called as a partial rebreathing mask. Partial rebreathing mask. And this works between 10 to 12 liters. It gives almost 70%. Right? So they made another mask like this, which is called non-rebreathing mask. Okay, this is the most important. And non-rebreathing mask is also called NRBM, non-rebreathing mask. And non-rebreathing mask at 15 liters would provide almost 90%. Thumbs up. So did you realize out of all the devices low flow, you find the non-rebreathing mask giving you the maximum oxygen. Right? When you speak of high flow devices, high flow is HFNC, high flow nasal cannula. This high flow nasal cannula can give almost 100% oxygen. This works between almost up to 60 liters of oxygen can go from this high flow nasal cannula. Right? It gives 100%. And the second in high flow is Venturi. And that's exactly why Dr. Nitya was thinking that this is providing you a high flow, because Venturi comes under high flow devices, right? The only thing is that we don't realize that though Venturi mask is working at high flow, the maximum would be 15 liters that you can use, correct? But the maximum oxygen that you can give with a Venturi mask is only 60%. This is the catch with the Venturi mask. The only advantage of Venturi mask is that it is a fixed output device. You know how much is going to be delivered to the patient exactly. When I use a nasal prongs, I'm not sure how much will get delivered to the patient. When I'm using a face mask, I expect it is 60%, but pata nahi jayega ki nahi. Same thing with non-rebreathing, but with Venturi mask, if I use the green one, I know it is 60%. If I use the red one, I know it is 40%. It's a fixed output device where I know how much is going, and it is high flow. It works at 15 liters, but gives only 60%. Thumbs up, guys. Is this point clear? This is the classification that you people need to know. This is an important point that you need to know. So remember, out of all these devices, yes, if high flow nasal cannula is given, no doubt high flow nasal cannula would be the maximum oxygen. Remember this point. If high flow nasal cannula is given, this would be the maximum 100% oxygen. But if high flow nasal cannula is not given, then the next answer would become non-rebreathing mask. So I've discussed with you the flow rates and I've discussed with you the maximum oxygen as well. Thumbs up, everyone. Is it clear? So this is the point to discuss for all the 5 questions that we were discussing. This was the discussion behind it. Thumbs up, guys. Is that okay? Clear? Any doubts, then ask me. In between, I'm looking down and looking at your messages. Right, Dr. Nitya says thumbs up. Yes, Dr. Akhil and Dr. Abhishek, other guys, all of you okay? I'll go forward then. Let me just show the diagrams also. So this is what was the nasal prong that I was talking about, right? Nasal prongs, as I said, which goes into the nose. This is the normal face mask, 60% at 10 liters. And then you have the non-rebreathing mask. Dr. Nitya, I will save. Abhi nahi, Dr. Nitya, मेरे को last में बोलना, last में. In the end, I need to save. All this is there right now, but I need to save in the end when I'm finishing of the class. I'll be saving it and giving it to you in terms of the Telegram group. Right? It will be uploaded over there. So all this will be the last minute revision before you go for the exam. Just read it once and you'll get these answers. Normally, they're going to ask you all these only, right? So without wasting any time, I'm just showing the diagrams also so that you people are aware what is what in case it comes. These are the points that they're paying attention. Okay? This is what is nasal prongs, nasal cannula. This is simple face mask. And this is the non-rebreathing mask. It has this reservoir bag. Can you see? The normal simple face mask does not have the reservoir bag. This is the difference between them, and that can be asked in the exam also. So remember, non-rebreathing mask is the one which provides the maximum oxygen out of all the low flow devices. Hopefully people have understood. Let me not waste any more time. So this is how it looks in the patient, right? This is how it looks in the patient. Non-rebreathing mask. NRBM. Next question. Again, Dr. Akhil says, and say video also. Dr. Akhil, I'll do that also. Done. Okay. Next question. Which of the following is the correct sequence of arrangement of inhalational anesthetic agents based on their potency? This was again asked in INI-CET. For this, you need to know the minimum alveolar concentration. Anyone, what's the correct answer? This has been asked, same question, same way. Few changes here and there, but almost the same way it has been asked. So yes, guys, any answer? Confusing, eh? I totally agree. Not very easy, but there's a way to remember that, and we'll try to remember it that way. Okay. So no answers till now. I haven't seen. Fine. So let me just give you the answer for this question. Just remember one point. M for methoxyfluorine, M for most potent, N for nitrous oxide, N for not potent. Right? That is one way. But in that case, you are getting two options where it will get confused, right? Based on potency. So the point is you need to know about halothane and isoflurane also. This is based on minimum alveolar concentration. Halothane is more potent than isoflurane. So therefore the correct answer here is A. Okay, the correct answer is A. Methoxyfluorine, most potent, nitrous oxide, not potent. This question is based on minimum alveolar concentration. What is minimum alveolar concentration? Minimum alveolar concentration, guys. Dr. Akhil says D. No, Dr. Akhil. I think, yeah, that's what I'm. Let me come to that point now. So just remember, we are discussing minimum alveolar concentration. I don't want to go into a lot of details, but minimum alveolar concentration is basically minimum amount of inhalational needed, okay, at which 50% of the patients do not respond to any stimuli or surgery stimuli, right? Just remember like this, minimum amount of inhalationals at which 50% of the patients do not respond to surgical stimuli. 50% do not respond to surgical stimuli. So basically क्या होता है? Minimum amount needed, okay, at which the patients do not respond to surgical stimuli. So minimum amount means it is telling you potency. So minimum alveolar concentration basically tells you potency. All right. What means if some drug you give less in amount and it produces anesthesia, it means it is more potent. If you give a drug more in amount and then it produces anesthesia, it means it is less potent. So can you see it is inversely proportional? A drug which is needed less, it can produce more anesthesia. A drug which is needed more, okay, is going to produce less anesthesia. So basically it is telling you comparison between two drugs, that is minimum alveolar concentration. For example, nitrous oxide. Let me take nitrous oxide. If you give 104%, then patients do not respond to surgical stimuli. Methoxyfluorine, if you give only 0.16%, okay, patient does not respond to surgical stimuli. So therefore, methoxyfluorine M becomes the most potent, nitrous oxide N becomes not potent. Okay, so this is the end of the spectrum. How to remember the things in between? So remember it like this: most potent, not potent, right? In between, you can remember is his dream is to take nitrous oxide. Okay, most potent M, not potent nitrous, and you can remember it as halothane, isoflurane, sevoflurane, and desflurane. Don't remember the values. These values are not important to remember for exam, any exam. Forget it. All this is not important. It's no point wasting your time on remembering the values, but just remember the sort of mnemonic: M for most potent, N for not potent, and you can still remember the other things as his dream is to take nitrous oxide. Clear? Where methoxyfluorine is more potent than halothane, more potent than isoflurane, more potent than sevoflurane, more potent than desflurane, more potent than nitrous. Thumbs up, everyone. Clear? Very clear. राइट, ये बस चार्ट याद कर लो. और सिमिलरली ना एक और क्वेश्चन आता है इसी के ऊपर, there's another question based on this, which is blood gas solubility, right? So what is blood gas solubility? What does it tell you? So when you speak of blood gas solubility, guys, right? So let me put it over here. So can you see blood gas solubility is also given by values. Nitrous oxide, forget this MAC, this we have discussed. This minimum alveolar concentration told you potency, and it was inversely proportional. Blood gas solubility means how much gas is getting soluble in the blood. Nitrous oxide, can you see it is not getting soluble in blood? Halothane is getting so much mixed in the blood. So if halothane is mixed in the blood, uska action kaise aayega? It's a good drug, I understand. But if it is getting mixed in the blood, wo brain mein kaise pahunchega? How will it go to the brain? So therefore halothane turns out to be slow acting. Nitrous oxide turns out to be fast acting. So you find it's an irony. Halothane is more potent, but it is slow acting. Nitrous oxide is less potent, but it is fast acting, right? And in anesthesia, we don't want drugs which are potent or not potent, because more potent can have more complications. We want better to use fast acting and newer drugs. So which are the newer drugs? Desflurane and sevoflurane. And that is exactly why sevoflurane and desflurane are comparatively less potent, but because of being fast acting, they are still used in anesthesia nowadays. Okay, so how can you remember this point now? The same ways that we remember methoxyflurane and nitrous oxide at one end of the spectrum, halothane, isoflurane, then there was sevoflurane, and then there was desflurane. So most potent, when it was potency, this was the most potent, methoxyflurane. Okay, this was most potent, this was the least potent, nitrous oxide. Now when it comes to blood gas solubility, it tells you onset of action. I just discussed the fast and slow. So isko ulta kar do. Methoxyflurane becomes the slowest. Halothane usse thoda fast. Isoflurane thoda fast. Usse fast sevoflurane. Usse fast desflurane. No, usse fast nitrous oxide. Small change and then becomes desflurane. This becomes the fastest. So this tells you onset of action. Slow onset. But this point is important, that's all. So this potency is said by minimum alveolar concentration, and blood gas solubility tells you onset of action. That's it. Thumbs up. This is all you need to remember. Forget everything else. This much is okay if you remember. Okay? Remind me to save it, as I said. Okay? Later on, when I'm finishing the class. Now, which of the following inhalational agents is potent enough and can be used as a sole agent for induction of anesthesia and can be safely used for endotracheal intubation also? This question has also been asked, I think, last year only. As I said, I'm discussing the last 5 questions, last 5 papers of INI-CET. Like May and November, I'm discussing 5 papers over the last 3 years. So these are the 3 years, last 5 papers. Yes, anyone? What is the answer to this question? Waiting for a response. So first, let's just read the question also. Which of the following inhalational agents is highly potent enough also? Right? Potent. It may be important, not important, the point. But more important is to read which one can be used as a sole agent for induction of anesthesia. It means I'm giving no IV drugs, right? And can be safely used for endotracheal intubation also. So Dr. Akhil has said C. Dr. Akhil, yes, in one way I might think it to be C, but the problem is you will have to think between two of them, C and D. Desflurane and isoflurane are out. They are out anyways, right? The question here is about induction of anesthesia, and this means no IV drugs are used And when IV drugs are not, means I'm not giving propofol, thiopentone, ketamine to the patient. I'm not using these IV drugs, right? I'm giving only inhalational agents. So inhalational agents, if I'm using, I will need to use an inhalational agent which is fast acting, sweet smelling, and not pungent. The two sweet smelling agents are these ones, halothane and sevoflurane. The remaining two are pungent, and because they are pungent, they are not used for inhalational induction. What is inhalation induction? If the patient is awake, if the patient is awake and then I hold a mask, no IV drugs, and I'm just using inhalational drug to put the patient to sleep, that is called inhalational induction, right? So in this case, I don't want to use a pungent drug on the patient. Imagine using a pungent drug when the patient is awake. She will hit me later on. Dr. Ayush Chaudhary says, Namaste ji. Namaste, Dr. Ayush Chaudhary ji. Namaste. Right. Let me just discuss these points out. Please answer the question if you're a part of this, right? And let me just explain these points out now. So Dr. Akhil and Dr. Nithya, Dr. Abhishek, the points people who were there before. So pungent is not what I want to use in this patient. Pungent rahega, there can be bronchoconstriction, bronchial irritation. I want a sweet smelling drug. What is the sweet smelling drug? Where the patient is comfortable, patient is happy. I want to use a sweet smelling drug. The two sweet smelling drugs are halothane and sevoflurane, right? Now, both of them can be used for induction of anesthesia. Both of them can be used for, and the next point is endotracheal intubation. So when you're doing endotracheal intubation, the question is sole agent. Means I'm using no muscle relaxant, which means which of the inhalational has muscle relaxant property. Again, this is a point when we study in pharmac, we have already discussed. S for sevoflurane, S for sweet smell, S for skeletal muscle relaxation. So sevoflurane causes the maximum skeletal muscle relaxation. Because I'm not using muscle relaxant, therefore sevoflurane can be used as a sole agent, not just for inhalational induction, but I can also use it for endotracheal intubation because it causes skeletal muscle relaxation also. Thumbs up, guys. So yes, our doubt would have been between halothane and sevoflurane. Both of them are sweet to smell, right? Both of them are there. These two are basically pungent. They can cause bronchial irritation. So they are not used for inhalational induction, right? So sweet to smell, both of these drugs are used for inhalational induction. But sevoflurane has got the maximum skeletal muscle relaxant property, because of which it can be used as a sole agent for intubation also. Okay, guys, that's the reason. And of course, halothane also has, I'm not denying, but maximum skeletal muscle relaxation is seen with sevoflurane. Okay, so I think this point is also done. Next, again, a question which was asked. Now, this was kind of a common question between surgery and anesthesia both. So, what is the most common cause of hospital admission after daycare surgery? Right? Post-operative nausea, vomiting, pain, respiratory distress, and bleeding. डॉक्टर अखिल ने थम्स अप दे दिया एंड मेरे को आंसर दे दो फिर नेक्स्ट क्वेश्चन का, then we'll take it forward from there. Fast, guys, fast. I'm looking down because I'm looking at your messages. Otherwise, I'll be looking straight. Right now, I haven't got the message. So let me give the answer. Dr. Akhil, Dr. Sunny says A, post-operative nausea vomiting. Dr. Akhil says D. Now, what is the answer? Now, the point is, actually, anesthesia textbooks don't give you this answer, right? Dr. Akhil says B, pain. Dr. Song. सही यार, सॉन्ग पे याद है, गिटार तो मेरे पास अभी भी रखा है. ठीक है, Dr. Songs. Dr. Song says D. Yes, I will go for D. Bleeding. And let me just discuss why this point is. If you see anesthesia textbooks, they say this is the maximum number of complications that you see is post-operative nausea, vomiting, and pain. This is the problem with daycare surgery, right? So let me just tell you as to why I will go for bleeding and why I will not go for these three. As I said, any answer can be given depending on which book the examiner has referred to From anesthesia textbooks, you'll find the maximum patients having a problem is post-operative nausea, vomiting. This is the maximum complication that you see, as well as pain, right? Or I'll say sedation or respiratory distress. So if I see anesthesia textbooks, you will find the most common complications given in anesthesia textbook would be post-operative nausea, vomiting. Then there is pain. Then there is drowsiness, because of which patient can't go home, and then there can be respiratory depression and sedation. So I'll say drowsy and respiratory depression can be because of sedation only, right? So these are the major complications which are given in anesthesia textbook. So according to anesthesia textbook, they have not said what is the cause of hospital admission after daycare. The question is, daycare surgery has been done. Patient को घर जाना चाहिए था, लेकिन patient को admit करना पड़ गया. क्यों admit किया? Why did you admit the patient though you were supposed to discharge the patient? So yes, according to anesthesia textbooks, they have not given hospital admission, but they have given complication can be post-op nausea, vomiting, pain, drowsiness, and respiratory depression, which can be there. So all these three. Lekin, if you will see the surgical point of view. So first is, what are the surgery? Right, Dr. Akhil, so I'm just coming to that point, right? So even surgery it is given. I'm not talking of surgery part. I'm not talking anesthesia. I'm talking surgery. I know surgery is not my forte, but surgery के हिसाब से the surgical criteria are what are daycare surgery? Simple surgery होना चाहिए. Minimum risk of post-op complication होना चाहिए. Minimum post-operative pain which can be controlled by analgesia. No special nursing should be needed, and prolonged immobilization should not be there. Less chances of DVT, and immediate return of food and fluid intake. These are the surgical criteria. What is the discharge criteria of a patient? If the vitals are stable for at least 1 hour, patient is well oriented, there is no dizziness while walking, right? Minimum pain and post-op nausea, vomiting, because we know it will take care. Minimum bleeding at the surgical site, which the surgeon will tell you. Patient has taken fluid, passed urine, some responsible adult, and everything is there. Time pass. Now, the point is patient has gone home, and then the patient feels dizzy. He will go off to sleep. Patient feels drowsy. He might just sleep. Some pain is there. You have given painkiller. Some post-op nausea, vomiting is there. You have given some medicine, right? But it is minimum bleeding which becomes increased. By chance it increases, and then the patient can't stay home. If the patient is dizzy, he can stay at home. If he has nausea, vomiting, he can still stay at home. If he has pain, he can still stay at home. But if he starts bleeding, in that case, he cannot stay at home. He has to come to the hospital. So according to me, the correct answer should be bleeding. That is according to me, because all other complications are there. If you will see, there are surgical complications of hemorrhage, nausea, vomiting, drowsiness. These are anesthesia complications. We are talking of patient as a whole. That's exactly how questions are coming. They're not asking you from surgery or from anesthesia. You have to apply your thoughts, your concepts, and think about it. So if I say from anesthesia point of view, there is nausea, vomiting, do you need to admit him? No. I will give him more medicines and see. If he's drowsy and dizzy, I'll try to give him medicine, right? If there is pain, I'll try to give him medicine and take care of it. So he does not need to get admitted because of that. But if there is hemorrhage, I can't tell him, यार तुम घर पे बैठे रहो, मैं आराम से बैठा रहूंगा. The surgeon will call him immediately to the hospital. You've gone home, come back. We need to admit and see why the bleeding is taking place. So according to me, the correct answer should be bleeding. What about post-op nausea, vomiting, and pain? Are these complications? Yes, they are very major complications given from anesthesia textbook. But because of that, the patient will not be discharged only. But basic hospital admission or readmission would be needed if there is bleeding or if there is surgical complication. According to me, this should be the answer. Akhil says thumbs up. Okay, that was the question according to me. Okay, other people might still differ, but I am saying I am applying my thoughts, my concepts, and from whatever I know, right? Now, so a question like this was asked, but I've changed it slightly. A 60-year-old male patient is undergoing laparoscopic cholecystectomy. Okay, joining device shown is being used to monitor adequate muscle relaxation. The mode used is train of 4. What should be the ideal frequency of the stimulus? Right, something like this has been asked. So I've just changed it slightly to ask you about the train of 4. What should be ideal frequency? Remember, it is INI-CET. They ask you such questions only. Right. Jaldi, so that I can see other we can just cover up other questions also, guys. Anyone? Okay, so let me go ahead and give the answer. Dr. Noor Alam says C. Dr. Sunny Surya says B. Correct. Dr. Sunny, absolutely correct. Dr. Sunny Surya says B. Absolutely correct. It is 2 hertz, right? And Dr. Noor Alam has said C. C nahi hota hai. When we are speaking of train of 4, it is 2 hertz. I'll discuss this point out. Next question based on the same thing. Remember, when you speak of train of 4, you are giving 4 stimuli, each of 2 hertz, and they are given in a span of 2 seconds. Remember this point, 2. Just remember, when you speak of train of 4, 4 hai na? Remember it as multiples of 2, 2 and 2. Means you are supposed to be giving 4 stimuli, right? 4 stimuli. So what is there? 2 hertz. And what is the time? 2 seconds. So 2 seconds, 2 hertz and 4 stimuli. That is how you remember in the exam. It becomes easy. Clear, everyone? So train of 4 is 4 stimuli, 2 hertz given in a span of 2 seconds. That is according to me what I feel, right? I mean, that is how I remember. Next question based on the same thing. This was what was asked in the exam, sort of, right? Same thing, but the mode used is tetany. In tetany, what is the ideal frequency of the stimulus? In tetany, same thing. What is the ideal frequency of the stimulus? So this is a physio question, anesthesia question coming together, right? So now you know the answer is not 2. Both options are the same. One option is ruled out. Dr. Sunny says C. Dr. और कोई आंसर? Dr. Sunny, here it. बाकी Dr. Akhil, Dr. Noor Alam and Dr. Nithya, Dr. Abhishek, बाकी लोग किधर हैं? चलो, let me give the answer fast and go to the next question. It is 50, right? 50. So when you are giving tetanic stimulation, guys, remember it is 50 hertz which is normally used. Okay, tetanic stimulation is 50 hertz. Remember, train of 4 was a small 2, right? 2 hertz. But when you speak of tetanic stimulation, it is normally 50 hertz. Continuous, tak 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 tak, जा रहा हूँ 50 पे जा रहा है. ठीक है? It is 50. It is 50. 20 to 50, right? I'm saying, yes, you must have studied in physio 50. I'm not denying. But normally what is used over a period of 5 seconds is basically 50 hertz what goes to the patient. In technique stimulation, what goes is 50 hertz, right? In physio books, I do agree it must have mentioned. In fact, 20 भी लिखा और 50 to 100 भी लिखा है. But normally it is 50 hertz which is used. Okay? Remember that point out. Whenever you're talking of technique stimulation, remember 50, 50, 50, 50. Okay? Okay, guys? 50 hertz. That's what we take. So let's go forward. 50-year-old female patients present to the pain clinic with history of chronic backache. This question has been asked twice. Same question. I'm not reading it. Mark your answers fast. Okay. So patient is presenting to the pain clinic with history of chronic backache. He is greatly troubled by it, unable to do routine activity. This has changed because of the persistent backache. Orthopedic and neurological consultation says no intervention. हम लोग बोलते हैं ना पागल पेशेंट है, मैड पेशेंट. We normally talk now when you're in a government hospital. You'll say, oh, backache wali patient. So anesthesia people are waiting. The pain physician is waiting. I am the one who will take care of it. Okay, so that is what is pain physician. Pain medicine. Super specialty of anesthesia. Pain management. Okay. No, there's no course per se, but people are doing fellowships in pain management. So the pain physician decides transcutaneous electrical nerve stimulation. What is the mechanism behind it? Yes, guys, descending inhibition, sensitization, central inhibition, gate control theory. Yes, anyone? हाँ जी, क्वेश्चन आंसर नहीं दिया अभी तक यार, आई वाज वेटिंग। चलो लेट मी गिव द आंसर। सिंपल क्वेश्चन है ये तो। यस, gate control theory, physiology, right? When you speak of physio, or when we speak of this, so normally what happens, okay, normally what happens is, if there is a stimulus coming, pain stimulus, for example, someone is having pain, right? So pain fibers, Dr. Surya and Dr. Akhil says C. अभी मेरे को अभी मिला यार, C नहीं है, गेट कंट्रोल थ्योरी है। Gate control theory. Gate control theory. We'll discuss it out. Okay, I'm just discussing then. Okay, this is physio. So what happens normally? You know that there are different types of nerve fibers. A alpha, A beta, A gamma, A delta, B and C. उसमें से A alpha is motor. These are sensory. B fibers are autonomic. This is sensory. Right? So pain is basically carried by A, delta and C. These are slow fibers. So what happens when someone has pain? This pain is carried from the nerves, from the periphery. It goes to the spinal cord, right? To the nerves, it is going to the spinal cord, and from the spinal cord, it is going to the brain, right? And the patient is feeling the pain. That is exactly what you people must have seen. A pain ka, this is called transduction. Transduction of the pain, transmission. It's a pain pathway. Transduction, transmission, modulation, and perception. Spinal cord modulation and perception. So you can intervene anywhere in between, right? This is how you take care of the pain. This is the pain pathway, right? Transduction, transmission, modulation, perception, and modulation of pain. So A delta and C fibers are basically carrying the sensation slowly, 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 slowly through the nerves, and it is going to the spinal cord. It is reaching the brain, and the patient has pain. So what you do is you start giving massage. Okay, you give massage. Good evening, guys. Dr. Sagar is also there, right? You give massage. और मसाज को छोड़ो, टेंस दे दो, ट्रांसक्यूटेनियस इलेक्ट्रिकल नर्व स्टिमुलेशन, राइट? उससे क्या होता है, व्हेन यू गिविंग मसाज और ट्रांसक्यूटेनियस इलेक्ट्रिकल नर्व स्टिमुलेशन, it stimulates the A beta fibers. These are mechanoreceptors. These are fast fibers, and they carry it very, very fast, very, very fast, very, very fast to the nerves, and they stop the A delta and C fibers from taking the sensation to the brain. So that is what is called as gate control theory. They go and stop that fibers from going to the brain. So this tense and massage is based on this gate control theory of pain. अरे तभी तो मसाज करने मजा क्यों आता है? You go to Thailand, Bangkok, अरे not even India में भी कहीं जाओ, Kerala massage, why you like it? You're lying like this and someone is massaging and everyone is enjoying that. You go for a holiday, you speak to people, what do they want? Everyone says we want a massage. Why you like the massage? A beta fibers. So in that case you should read ना, थोड़ा पढ़ोगे तो समझ में भी आता है, ठीक है? A beta fibers are fast acting. They go in front and they stop the perception. They go for they prevent the A delta and C fibers. इनका जो slow acting, can you see these are slow acting fibers carrying the pain signal slowly, slowly they are carrying it to the spinal cord. So when you activate the A beta fibers, these are very, very fast and they prevent the other stimulus from A delta and C to go to the brain. And this is the reason why the pain is not perceived, or patient does not perceive, it's not received to the brain. That's why you feel good after a massage. In fact, when we get injury also, if I injure my hand, have you seen if you injure your hand, initially you press it lightly and you feel good. Okay, everyone does that. So that is the gate control theory of pain. Next, during resuscitation, a patient received IV bolus of 20% intralipid, which what could be the most probable cause of cardiac arrest? Pulseless electrical activity, electrocution, local anesthesia, systemic toxicity, asphyxia due to drowning. Yes, guys. My eyes are down because I'm looking. Yes, I got one answer from Dr. Akhil. Yes, so Dr. Akhil, absolutely correct. Absolutely correct. This question has been asked before. And this is local anesthesia systemic toxicity. Dr. Sagar also says C, and Dr. Med Psycho. सही नाम है यार, मस्त नाम रखते हो तुम लोग. Med Psycho. I like the name, Med Psycho. एक डॉक्टर सॉन्ग्स भी थे. C, local anesthesia systemic toxicity. Right? Absolutely correct. So why is intralipid being used? So no, routinely what happens, it is used as one of the treatments nowadays. So what is intralipid? This is what is called intralipid. Intralipid, guys, is basically the same thing which is used for TPN, total parental nutrition in the ICU, which contains lipids, right? So what does it do? Why do you want to use an intralipid? Basically what happens, okay, next question. Okay, forget the question because I've got so many questions, we'll not be able to discuss. Let me give you the answer straight away. The most cardiotoxic local anesthesia drug. The most cardiotoxic local anesthesia drug. So they'll give you 4 options, but you people should know it is bupivacaine. Now, bupivacaine, guys, is that local anesthesia drug which causes maximum cardiotoxicity. Routinely, all local anesthesia drugs, you will find CNS complications taking place before serious complications. But in bupivacaine, you find the serious complications occurring at the same time as CNS complications, because of which it is so dangerous. The most common CNS complication is convulsion. Not the first. The first complication is circumoral and tongue numbness. But the most common which is seen is convulsion, and in serious it is arrhythmia. Remember, CNS complications can be reversed. Serious are normally not reversed. That is the problem. So therefore, these arrhythmias which are produced, how will you take care of that? Of course, you'll try to give antiarrhythmic agents. But apart from that, they found that the intralipid, what does it do? If you give intralipid, the complexes which is there by bupivacaine, it works like a binding agent. You know, people have heard binding agent or chelating agent. It works like that. It kind of binds to that bupivacaine complexes and takes it away from the body, and that is how it works. So it has now been added, 20% lipid emulsion has been added in case when there is local anesthesia toxicity. Of course, you were doing ABC, CPR, everything is a part of it. ABC, CPR is a part of it. But in lipid emulsion becomes a very important point as one of the parts of treatment for this. Okay. So therefore, this was about lipid therapy, intralipid therapy. So basically you are giving it bolus. After that you can start an infusion, and the bolus can be repeated if there is asystole which is seen, right? Okay. So going forward, next question, mechanism of action of local anesthesia drugs. I think all of you gave me the correct answer. Dr. Akhil, Dr. Sagar, Dr. Sunny, Dr. Med Psycho, Dr. Noor Alam. अब तुम सोचो, मैं YouTube पे तुम्हारे को मेड साइको बुलाऊंगा तो कैसा अच्छा लगता है दिखने में. I mean, your name would be so good, na? And I'm referring to you as Dr. Med Psycho. PW Doctor. Next class by PW Doctor. I'll think of good names for myself. Educated drug dealer. Next time when you see physics wala, PW MedEd, so they will write, on the channel. You should put anesthesia class by educated drug dealer. Sorry, I'm just waiting for the answers. Okay, so Dr. Akhil, Dr. Noor Alam, Dr. Akhil has given an answer. Baki ke log? Right. I think. Dr. Sagar says I'm a NEET student. अरे कोई प्रॉब्लम, NEET या UG, Dr. Sagar, तो NEET PG क्यों सुन रहे हो बैठ के? समझ में आएगा भी एनेस्थीसिया? Okay, Dr. Akhil, Dr. Med Psycho, Dr. Nithya and Dr. Noor Alam, absolutely correct. A. ठीक है, मेरे को लगता है सबको पता है आंसर. Let me not go into much details of it. Remember, local anesthesia drugs, they work at sodium channel. Remember, not just sodium channel, they have the capacity to work at potassium also, calcium also, and chloride also. But the maximum effect takes place at sodium channels. That's the point. Okay, remember this. I think all of you have given me the correct answer. ठीक है, it inhibits the sodium channels. So routinely क्या होता है, when you speak of these drugs, local anesthesia drugs, what happens is on the nerve, the local anesthesia goes like this. It is jumping through the sodium channels. So sodium goes inside and the signal jumps. That conduction that takes place, it jumps. Sodium goes inside and it jumps. Sodium goes inside and it jumps. That is how local anesthesia works. Action potential goes forward this way. So when you give local anesthesia, what happens? At one point, it goes and blocks that sodium channel. So for example, now the action potential jumped from here to here. Then action potential jumped from here to here. After that, it came here. But local anesthesia has blocked that channel. Because of this, now sodium can't go inside, and this action potential has blocked here itself. So the patient does not feel the pain, and this is how it takes care of it. So it is basically stopping or blocking the sodium channel. It is inhibiting the sodium channel, and that is the reason for the action. It inhibits the sodium channel. It prevents the sodium from going inside. So when you find local anesthesia drug, can you see? That is what is called lipid solubility. It penetrates through the lipid membrane. It goes inside the cell, and inside the cell, local anesthesia goes and blocks it. It blocks it from here. So now sodium can't enter inside now, because action potential came till here, and it was coming. When sodium was going inside, it jumped. Sodium came inside, it jumped. But now local anesthesia has blocked it. So sodium can't go inside and action potential can't go forward. Okay. Dr. Med Psycho says, thank you, sir. Med Psycho means medical professional syllabus. अरे मुझे नहीं पता था यार. You people are new ना. मैं तो I am from the old generation. You people know it better than me. Okay, good name. I also remember it. ठीक है. Right. Next question. So that was about the local anesthesia mechanism of action. Acha, one more question based on that. Let me ask you here itself. Malignant hyperthermia. It's a disorder of which channel? Sodium, calcium, chloride, calcium. Fast. Jaldi, jaldi. Next question. Fast. It has been asked before. Fast, guys. Sodium, calcium, chloride, potassium. डॉक्टर श्रीकांत has given an answer. ये इंपॉर्टेंट है यार. ये नीट पीजी का क्वेश्चन है, तभी मैंने पूछा. ये नीट पीजी में पूछा हुआ क्वेश्चन, ये एफएमजी में भी पूछा है. देव आस्क्ड इन द एफएमजी आल्सो. नहीं, सोडियम नहीं है ना. दैट इज व्हाई यार इंपॉर्टेंट. सो आई विल डिस्कस दिस पॉइंट आउट विद यू. रिमेंबर गाइस, मैलिग्नेंट हाइपरथर्मिया इज कैल्शियम. कैल्शियम गाइस, कैल्शियम. रिमेंबर दिस पॉइंट. कैल्शियम. मैलिग्नेंट हाइपरथर्मिया क्या होता है? रिमेंबर, मैलिग्नेंट हाइपरथर्मिया अकर्स. डिस्कस कर लें क्या ऑल ऑफ यू? मे आई? एक सेकंड में डिस्कस कर लूं? एक सेकंड तो नहीं होगा, 2 मिनट में डिस्कस कर लेते हैं. राइट डॉक्टर अखिल, कैल्शियम. करेक्ट, कैल्शियम इज द पॉइंट. करेक्ट. Dr. Akhil has given the correct answer. Remember guys, what happens is malignant hyperthermia is a genetic disorder of sarcoplasmic reticulum. This question was not included in my discussion. I was thinking, but I thought I'll discuss with you because it's an important question. Genetic disorder of the sarcoplasmic reticulum having the ryanodine receptor gene abnormality. Now ryanodine receptor is a calcium release channel. इससे calcium release होता है. Sarcoplasmic reticulum is present in all the muscles in the body. Correct. पूरे body में है ना sarcoplasmic reticulum, ryanodine receptor, हर जगह. It's a calcium release channel. So what happens? It's a genetic disorder. So a patient having the genetic disorder, and to that patient you give anesthesia drugs. Most commonly halothane or any volatile anesthetic agent, succinylcholine, or if you give lignocaine, local anesthesia itself. What happens is that from all the muscles of all the body, from all the sarcoplasmic reticulum, something goes wrong with the ryanodine receptor, and the calcium channel starts to release calcium in the body. पूरे body में calcium release हो रहा है. पूरे body का calcium, पूरे muscles में जितना calcium है सब release हो रहा है. In all the muscles, how much ever calcium is there, सब का सब release हो रहा है. So therefore क्या होता है? This calcium, because of so much calcium release, has changed the electrolytes in the patient. Electrolyte abnormality हो गया. It will lead to arrhythmias. The increased calcium has increased the metabolism. So therefore there is increased carbon dioxide production and fever in the patient. because all the muscles of their body is involved. ये fever जो है नीचे decrease ही नहीं होगा ना, hence it's called malignant hyperthermia. Because the muscles are getting involved, the urine changes called myoglobinuria will be there. These are the symptoms. The only treatment is that you have to stop the calcium release, and the only treatment for that is next question asked in the exam, dantrolene sodium. Thumbs up everyone, clear? Dantrolene sodium is the treatment of malignant hyperthermia. Okay, hopefully clear. So we've discussed malignant hyperthermia in 1 minute. That's why the symptoms of malignant hyperthermia are basically because of electrolyte abnormality. You get arrhythmias, increased carbon dioxide production, that is seen on the soda lime container, capnography, fever, patient starts sweating, temperature increases, and myoglobinuria. Treatment is dantrolene sodium. This is the only treatment, dantrolene sodium. It stops the calcium release. ठीक है, चलो एक अच्छा पॉइंट डिस्कस कर लिया हम लोग ने फास्ट. नेक्स्ट क्वेश्चन, विच ऑफ द फॉलोइंग लोकल एनेस्थीसिया एजेंट प्रोड्यूसेस हाइपरटेंशन? यस, जल्दी जल्दी. डॉक्टर साई, डॉक्टर तेजा साई. राइट, डॉक्टर तेजा साई फर्स्ट आंसर दिया, एब्सोल्युटली करेक्ट. कोकेन, कोकेन यार, यस एब्सोल्युटली करेक्ट. नूर आलम, मैंने बोला ना एजुकेटेड ड्रग डीलर, माय ब्रांच इज ओनली मेड अप ऑफ कोकेन. करूं क्या? Okay, if someone says, sir, why did you speak about cocaine? I can't help it, yeah. My branch has been made of cocaine. Remember, cocaine was the first local anesthetic ever used. It is the only naturally occurring local anesthesia agent. मेरे पूरे ब्रांच में नशेड़ी थे, नशेड़ी, तभी ये ब्रांच बना है. That is how anesthesia came. That's why you find anesthesia people so cool. Look at the medical colleges, na. You go to any medical college, any government or private, anesthesia people are cool. डूबे में रहते, ऑलरेडी नशे में रहते, सुबह से लेकर रात तक. यू आर चेंज इनटू योर स्क्रब्स, यू आर एंजॉयिंग हेवन. ठीक है, ओके, दैट वाज ऑन अ लाइटर नोट. अदरवाइज एवरीवन विल से, सर, ऑल ऑफ अस विल पिक अप एनेस्थीसिया पीजी, राइट? टॉकिंग अबाउट कोकेन, remember when we speak of lignocaine, bupivacaine, so Dr. Shrikant had said bupivacaine. No, Dr. Shrikant, the one that can cause hypertension is cocaine, and the reason is that, now I'm giving you the reason for that, all the local anesthesia agents, when you speak of local anesthesia agents, all of them, all local anesthesia agents are normally vasodilator. What is vasodilator? Basically, they are going to, wherever you're injecting local anesthesia drug, they will dilate the blood vessels, because remember, local anesthesia is injected inside the tissue, right? And from the tissue it goes and works at the nerve, but remember, inside the tissue there are going to be blood vessels also, right? So therefore local anesthesia, therefore being a vasodilator at the blood vessel, that's exactly why you get lignocaine plus adrenaline, na. Why you get a drug called lignocaine plus adrenaline? Because when you inject local anesthesia into the tissue, a lot of drug will go to the blood vessel and cause vasodilation, so the action at the nerve will decrease, hence you have lignocaine plus adrenaline, so that it causes vasoconstriction at the blood vessel and more drug then goes inside the nerve. Right? Dr. Akhil is telling ketamine का नशा. हाँ हाँ, ketamine नहीं, सब चीज का नशा है यहाँ पे. तभी ने बोला नशेड़ी ब्रांच, एजुकेटेड ड्रग डीलर. ठीक है. Now coming back to other studies, as you are talking about, right? So it works at the nerve, right? And the only problem is that it can cause vasodilation, because of which we use lignocaine plus adrenaline wherever possible, right? The use of this adrenaline is the same reason, because all the local anesthesia drugs have vasodilator properties, except, that is the point, all local anesthesia drugs are vasodilators except, most important, cocaine. Remember guys, cocaine is a vasoconstrictor. Because cocaine is a vasoconstrictor, remember, you can't use adrenaline with that. Again, MCQ question, so contraindicated with adrenaline. Cocaine should not be used. Another point, cocaine being vasoconstrictor, because of which it increases the blood pressure, so that's why it is causing hypertension. Apart from cocaine, is there any other vasoconstriction? Yes, there are. Mild. Other mild vasoconstrictors are ropivacaine. ropivacaine is considered a mild vasoconstrictor, and even levobupivacaine is considered mild vasoconstrictor. These are S enantiomers. Okay, thumbs up, guys. So the mild vasoconstrictors are ropivacaine and levobupivacaine. But cocaine is a vasoconstrictor, so therefore the correct answer is cocaine. Next question. Match the dilution. Typical INI-CET question. Okay. Match the dilution of adrenaline to its use. Which one? Typical question. And you know when you get a question like this, you're sitting in INI-CET exam, right? That's exactly why it makes it different. Now they've asked you 3 questions in one, and you're supposed to answer them. Okay. Match the dilution of adrenaline to its use. Yes, guys, what is the answer here? What do you think? See, that is why normally the same question will come in FMGE or NEET PG as a single thing. You know, what is the dilution to be used for cardiac arrest? What is to be used for anaphylaxis? What is used for local anesthesia? So Dr. Tejas has given an answer. Dr. Rahul Sharma. Me also see यार, मैं तुम लोग से बात कर रहा था, मैं देखा नहीं. So cardiac arrest is when supposed to be used. Normally, remember, you will be giving IV, and the IV dose is going to be this one, right? 10,000. Anaphylaxis is immediate. You will give IM, subcute, whatever possible, immediate. This is 1:1,000. And for local anesthesia, we use anywhere between 1:50,000 to 1:2 lakh. Anywhere is used, right? So for local anesthesia, when you're giving, you use it between 1:50,000 to 1:2 lakh, anywhere in between, right? So normally 1:2 lakh is the most commonly used, but 1:1 lakh is also used. So that goes for local anesthesia. So C remains 3. All right. A will become, where is A? Answer. A का answer 2 है, B का answer 1 है. So our correct answer is this one, B. Right. So everyone has given me a correct answer. Dr. Rahul, Dr. Tejasai, Dr. Nithya, Dr. Shrikant. Right? Everyone has given me a correct answer. Let's go to the next question then. Okay? Nothing new to be discussed over here, but it is important to know these dilutions on concentration. It is asked in the exam. Also remember, in cardiac arrest, you prefer IV, or anaphylaxis mein IM, subcute, whatever you're giving, local anesthesia, wherever you're injecting into the tissue. This was last year's question, controversial question. Okay, mark your answer. This is again last year's question only. Huh? So 60-year-old female has to undergo femoral artery catheterization under local anesthesia. Okay, femoral, remember, artery catheterization. The local anesthetic is injected below the inguinal ligament. Okay, which of the following nerve is blocked in this patient? So there was a big controversy also. I mean, as usual, the INI-CET questions are all controversial only. There's nothing non-controversial about them. So Dr. Rahul has given an answer. Yes, other people? Fast. Then we'll go to the next questions. Dr. Akhil. So 2 of them have given me the absolutely correct answer. Let me put it forward. Correct. It's the femoral nerve. Absolutely. A lot of confusion was there when last year also when things were there. So people had said it might be genitofemoral also. See, lateral cutaneous and obturator nerve was out. But the biggest problem or discussion always was between the students who had appeared was between genitofemoral and femoral. So remember, genitofemoral na, let's see the anatomy and the way question is asked. Femoral artery catheterization, guys, is something when you're putting a catheter in the femoral artery. For example, you want to do a angiography. So for that, you'll put a catheter. So where is the femoral artery? So vein, artery, nerve. We have studied right from our childhood. Vein, artery, and nerve. Correct? Vein. Always it is like that. Okay. So now you are supposed to be putting a catheter here in the artery, femoral artery. You are supposed to be injecting below the inguinal ligament. So where is the inguinal ligament? This is the inguinal ligament. Correct. You are injecting it below. So below, where will you inject so that you get a block? I am injecting a catheter over here. My catheter has to go from the femoral artery below the inguinal ligament, and my catheter will then, go ahead. No, this color nahi hai. Let me take another color. So my femoral artery catheter will go from here and will go here like this. It will go to the heart. right? But my point of puncture would be somewhere here. So where would you like to inject local anesthesia so that you can do it here? Correct, near the femoral sheath. So when you're injecting in the sheath, remember I just discussed with you local anesthesia is injected inside the tissue, and from tissue it gets absorbed inside the nerve. Apply the same thing. It will get absorbed to the nerve, and plus there are blood vessels also. Do you realize? And blood vessels mean there is vasodilation, and that's exactly wherever possible we use lignocaine plus adrenaline, because this blood vessel will get dilated. So all the drug will go inside the blood vessel. Thumbs up everyone, concept clear हो गया? I know एग्जाम तो अभी आ रहा है, बट कंसेप्ट तो कभी भी क्लियर हो सकता है. पढ़ाई तो पढ़ाई होती है. जो concepts are clear, things become easy, right? The same thing we discussed a while back. Same point, it is causing vasodilation. So now, I mean, I used that point to discuss over here, but now coming about the question. So when I want to you put a femoral catheter, I want to give it near this area. So which nerve is getting blocked? Femoral nerve. Correct. Which nerve is this? Femoral nerve. Has it got divided here? No. This nerve is what is femoral nerve. So therefore the correct answer becomes femoral nerve. Why not the other nerves? Let us see that point. When you speak of lateral cutaneous nerve, it is over here. But femoral artery is to be inserted here. Catheter has to be inserted here. When you speak of genitofemoral nerve, it is here, above the inguinal ligament. This was the inguinal ligament. So what you're getting below the inguinal ligament is the femoral branch, and you're getting the genital branch. Okay, so you are not getting the proper genitofemoral nerve below the inguinal ligament. This is all anatomy, yeah? Sorry, but that's how questions come in the exam. Okay, so genitofemoral nerve is here, but it gets divided here. Basically, we'll find the femoral branch and the genital branch. I may be wrong, huh? I'm just sharing my knowledge with you guys. So if you are injecting it in the genitofemoral area, I mean, it goes above the inguinal ligament. So therefore, the genitofemoral, according to me, is not the correct answer. Lateral cutaneous nerve is not the correct answer, and obturator nerve is somewhere here. Can you see? Obturator nerve will be somewhere here. Okay, somewhere here you're going to get. Obturator nerve is coming right above, and then it gets divided like this. So again, this is not the right answer. So obturator nerve is not the right answer. Genitofemoral nerve is not the right answer. Lateral femoral cutaneous nerve is not the right answer. The correct answer is what? Femoral nerve. Okay, this is our femoral nerve. You will give it in the sheath as Dr. S has pointed out. Absolutely correct. Correct answer is femoral nerve. Let's go forward. Next question. Sometimes the INI-CET people give you simple questions also to give you a break, right? So the joining set of instruments are used where you can't give all the questions as a confusing, no? So some questions have to be simple. So this is one of those simple questions. Yes, guys. Jaldi, so that we go to the next question. Okay, I think it's correct. Yeah, I think everyone would know what I'm talking about. It is seen. Right, Dr. Akhil had his hand on the buzzer. Buzzer, Dr. Tejas I also. Buzzer, press it, you get the answer C. Correct, all of you are right. Airway management. This is showing you basically, you can see, you have the laryngeal mask airway. I could have gone within 1 second, but I'm just telling you this contains all the instruments also. If it comes in the exam, try to identify. Why am I showing you this diagram? This is a classic LMA. Remember this. Classic LMA. This which you see over here is proceed LMA. Each of them are individual questions, guys. Each of them. This is a proceed LMA. This one. This is what is called as a oropharyngeal airway. This is what is called as the nasopharyngeal airway. And this is our endotracheal tube. And can you see something behind this is called stellate? That is the point I'm discussing this. Okay. So remember, in the same diagram, you can see 4-5 things. I can see a classical LMA, right? Classic LMA. Beyond, next to it, what I see is a proceed LMA. Remember, proceed LMA can be used for IPPV. Classic LMA was first generation. Proceed LMA is second generation, because through proceed LMA, I can give positive pressure ventilation to the patient, right? Because proceed LMA, guys, is giving you a drain tube from where you can put a nasogastric tube which passes right into the stomach. It's giving you a drain tube. So that's the difference. Can you see between the classic LMA has got just one tube, right? But proceed LMA you will find as 2 tubes. And the second tube is to put a Ryle's tube that can go inside the stomach, because of which you can give IPPV. So the first one was the classic LMA, and the second one that you see is a proceed LMA, right? Then you have the oropharyngeal airway, nasopharyngeal airway. You people are aware of that. This is nasopharyngeal. Then there is the endotracheal tube, and this is the stellate. Right. Then you will see this is the laryngoscope. Question asked, what kind of laryngoscope is this? So apart from Procele, classic LMA, we looked at the oropharyngeal airway, nasopharyngeal airway, there is endotracheal tube, and there is also laryngoscope. My question, what is the type of laryngoscope, guys? This laryngoscope is what? Which one? Which one as in? Let me give you the options. Is it Macintosh? Is it Miller? I'm making a new question. Huh? You people know me, na? मेरे को question आता है. I make the questions then and there. People who have seen my lectures, who have attended my lectures before will be knowing that. When I take MCQ sessions, that is how it is. Macintosh, Miller, McGill, McCoy. Fast. Which is the answer? A, B, C, and D. What laryngoscope is this? What laryngoscope? So this is a laryngoscope. Dr. Teja Sai says Macintosh. Correct, Dr. Teja Sai. Absolutely correct. This is Macintosh. Remember, Macintosh is a bigger name. So Macintosh is used in adults. Right? Miller is a smaller name. This is what is used in children. McGill is not used nowadays. McCoy is used for difficult airway. If you don't remember McCoy, it's okay. But you need to remember Macintosh and Miller. Alright? Remember, Miller is the straight blade and Macintosh is the curved blade. Again, that's an important question. Macintosh blade is a curved blade, which is used in adult. Because here you have to exclude the epiglottis, right? In children, you need to include the epiglottis. And that is why Miller blade, which is a straight blade, is used in children, because you need to include the epiglottis. Straight blade used in pediatric patients or children. Right? And I told you about McCoy. McCoy was a hinge tip blade. It has got a hinge tip blade that is used for difficult airway. So the airway point is also done. I think all of you see all these points is clear with everyone. देखो एक और अच्छा नाम दिखा मेरे को, डॉक्टर सल्कस गायरस. That's why यार medicos are so, मतलब yes, दिमाग है ना, IQ. This is the IQ with medicos. Look at the kind of names. ओके, डॉक्टर सल्कस गायरस ने पहले भी आंसर दिया था, बट आई सॉ डॉक्टर सल्कस गायरस का नाम मैंने अभी नाम देखा, डॉक्टर सल्कस गायरस. ओके, अनदर कंट्रोवर्शियल क्वेश्चन, बट this has been asked last year again. Some students had marked some answer, some students had marked other answer. So we'll discuss this point regarding to this question. Okay. So this was regarding rapid sequence induction. This was asked last year. As I said, I am discussing the last 5 papers which have been asked. I'm discussing most of the questions which are there. So this was one of them, and lots of students had a issue with the points over here. With the discussions of the answers that they had marked. Then yes, Dr. Rahul Sharma has said C. Yes, anyone else? See, first read the question यार. Problem लोग question ही नहीं पढ़ते हैं. Which of the following is not correct regarding rapid sequence induction? So for that you need to know what is rapid sequence induction, right? Then you need to know what are the steps in rapid sequence induction, and then you need to identify, of course, which one of them is not there as a step of rapid sequence induction. Okay? ये डॉक्टर राहुल ने शायद इसी का आंसर दिया ना. Other people? So I'm just waiting for your answers, guys. Other people, jaldi. Dr. Rahul says A. Right, Dr. Rahul, now correct. Absolutely correct, Dr. Rahul. Absolutely correct. A. Dr. Rahul has given the correct answer. A. Absolutely correct. Okay, which is not correct. So it is not to be used for cardiac patients. So now what is rapid sequence induction? So rapid sequence induction, guys, is what is done in a full stomach patient. I'll rather put it like this, rather than putting full stomach. Rapid sequence induction is called RSI. It is supposed to be done for full stomach patients. And more than full stomach, the biggest problem for full stomach is what? These patients are at a risk of aspiration. Right. So whosoever is at risk of aspiration, we will try to use, so Dr. Akhil also says A. Correct guys, आप लोग का message मेरे पास late आया, ठीक है, but absolutely correct. Answer is A. So first let me discuss the steps of it. So full stomach patients में risk of aspiration का chances होता है, and in full stomach if you want to get a surgery done and there is risk of aspiration, so I might have to intubate the patient, right? For that I have to give GA. Imagine I have to get a general surgery done under general anesthesia like perforation peritonitis and the patient is full stomach. Here I need to intubate the patient, but the problem is if the patient is full stomach, when I intubate, there's going to be risk of aspiration. I need to decrease it. So what are the steps? I can't intubate the patient directly because when I'm giving a normal anesthesia, I will give an induction agent, I will give a muscle relaxation drug, and I will wait for 3 minutes for the effect of muscle relaxation to take place. For those 3 minutes, you will be giving IPPV to the patient. The problem is in a full stomach patient, remember, is contraindication for IPPV. No positive pressure ventilation, no bag mask ventilation. You can't do it. So rapid sequence induction involves 3-4 steps. First is pre-oxygenate the patient, which means give 100% oxygen for 3 to 5 minutes, right? This will fill up the lungs with oxygen so that कोई desaturate नहीं हो, saturation कम नहीं हो जाए, right? For that reason, before you give your drugs, then what you will do is you will give your drugs. Drugs would be the drugs which are used for full stomach patient. Drug of choice is ketamine. Nowadays, people are using thiopentone and propofol also. And after that, our drug of choice becomes succinylcholine or rocuronium. So these are our induction agents, and this is our muscle relaxant. Now, by the time you're doing it, remember, the main thing is you're supposed to give cricoid pressure, which is also called as Sellick's maneuver, right? What does Sellick's maneuver do? It compresses the esophagus. Okay, what do you do in Sellick's maneuver? Basically, I'm putting a pressure on the cricoid cartilage. See, that's why it's cricoid pressure. Cricoid in the trachea is the only complete ring. So if this is trachea, in the trachea, all are half rings. It's only cricoid which is a complete ring. और trachea के पीछे होता है esophagus. So if you press the cricoid, what will happen? The esophagus at the back gets compressed because cricoid is a complete ring, right? So therefore, in case regurgitation takes place, it will get stopped because of cricoid pressure, and that is what is called Sellick's maneuver, right? So cricoid pressure is given 30 Newton, and then you intubate the patient. After that, you inflate the cuff, you confirm the position, and only then when you know that your tube is correctly placed, so once I know that my tube is correct, only then you're supposed to release cricoid pressure. Okay, so from here, let's see what things are there. Remember, inflate the cuff is important. This is the procedure. So now if I go to cricoid pressure, what steps are done? Pre-oxygenation is done. Yes, this is done. Are induction agent and muscle relaxant given simultaneously? Some people had said no for this, but I think yes, you can give both of them immediately. You give them immediately. Can you see? You're supposed to give ketamine followed by succinylcholine immediately. You're giving. You're not wasting any time there, right? And then after that, what will be done? Intubation should be done with high volume and low pressure cuff. Yes. Nowadays, this is what is used now. These are the PVC tubes. They're not red rubber. So PVC tubes are tubes like this, which are high pressure and high volume and low pressure, which means the volume in the cuff is high, but the pressure here is less. Pressure is less, and here the volume is high. So high volume, low pressure, so that tracheal damage does not take place. So all these three are correct. Cardiac arrest. Imagine someone is in cardiac arrest, means patient is almost dead. In that patient, do you want to give cricoid pressure so that you can prevent aspiration? No, guys. Remember, cricoid pressure is supposed to be done when surgery is planned under general anesthesia. A patient will full stomach, he comes for surgery under general anesthesia. And then I want to intubate the patient. If the patient is come in emergency, forget rapid sequence induction. वो तो मरा हुआ patient है यार. Forget aspiration. It's okay. We'll deal with aspiration later on. If it's a cardiac arrest patient, in that case, rapid sequence is not important. This patient is almost gone. You will first try to give CPR. You would like to save the life of the patient, and then aspiration we'll discuss later on. Thumbs up, everyone. Is this point clear? So CPR is important in this patient, not rapid sequence induction. Imagine, because rapid sequence induction is the use of your ketamine, succinylcholine, rocuronium. In a dead patient, why you want to use ketamine, succinylcholine, and rocuronium? RSI is not needed there. Rapid sequence induction. Required pressure is not needed. Thumbs up, everyone. Is it clear? This is according to me. Let me be very frank. Other people might have other opinion and other thoughts about it, but this is according to me the concept. अरे thumbs up. तुम लोग हो वहां पे? Are you there? Waiting for a response. Dr. Shrikant, हाँ, Dr. Shrikant के साथ हाथ है. Thank you, Dr. Shrikant. I'll also say the same thing, Namaste, thank you. Dr. Shrikant has said yes. Okay. Now let's go forward. Next question here. Okay, that RSI was important. Dr. Nithya also said thumbs up. Okay, right. Simple question. Kindly identify the marked point on that joining image. Okay. Dr. Tejas, I also gave a thumbs up. Thank you, guys. Thank you. Hopefully you understood the point. Okay. Right. So next question. Okay, it's a simple one actually. Okay, so kindly identify the marked point on the adjoining image. Right, so marked point is this one. Marked point is this one. This. Okay, ye hai marked point. What is it telling you? So they are not asking about the graph directly. What is the point telling you? As you can see, it is written also EtCO2. Sometimes questions are simple, and normally this will be given to you. If they are asking you something like this, they don't expect you to know everything about it. So I think all of you are correct, right? So here the answer is value of capnography. What is capnography? Capnography is carbon dioxide coming out and you plot a graph. So whenever the carbon dioxide goes up, okay, and carbon dioxide is getting released. So this is what is carbon dioxide. Okay, so you get a graph and this is the level of carbon dioxide that you will see. In fact, EtCO2 is approximately the same as PCO2. It is telling you the carbon dioxide of the patient. So whenever the graph is going down, it is oxygenation, right? So whenever CO2 is detected, it will produce a graph. So this is telling you about the CO2 coming out of the patient, right? Capnography. So this is capnography. It's not expired oxygen, not pressure of gases. The pressure of gases normally is written as, in a ventilator also it's written as airway pressure, peak airway pressure or something like this. It comes like this. Inspired oxygen and expired oxygen. So it will not be written EtCO2. If it is even our oxygen, this will be written as EtO2 or ET gas, any gas. It's written like this nowadays on the ventilator, right? This is expired. Inspired would be written as inspiratory. I'm telling you the normally nomenclature. Maybe it is not asked in the exam, but I'm just telling you the nomenclature. In case you find something written as expired, it will be written as ET or expired, something like this. If something is written inspiratory, it will be given inspiratory pressure. Okay, and P is what is the pressure which you will see. Okay, pressure of the gases, peak airway pressure or something would all be coming as pressure. So P will be there, right? If it is airway pressure, it will be peak airway pressure, right? Plateau pressure comes like this, P plat, right? So P is what indicates the pressure, right? This is about EtCO2. Okay, remember EtCO2 mein, they can ask you few graphs also. So you need to know this is a graph where EtCO2 becomes zero. So this is seen in esophageal intubation, right? This is seen in embolism. This is seen in cardiac arrest. This is seen in disconnection from the circuit, or this is seen in accidental extubation. I'm just discussing in short. If you get a graph like this, it means more carbon dioxide is there. This is basically seen in malignant hyperthermia, more carbon dioxide production, inotoxicosis, right? Fever, sepsis, laparoscopy, more carbon dioxide. If you get a graph like this with a baseline not touching zero, this is rebreathing, own carbon dioxide. You get something like this, shark fin appearance, means carbon dioxide coming slowly. This is what is seen in obstruction, COPD, asthma, right? If you get a graph like this, it tells you curare notch, patient is coming out of muscle relaxant effect. Okay, patient is out of muscle accident effect. Right? You get a graph like this. Ulta. It was like this, it is fine, but if you start getting a graph like this, going down like this is more to do with emphysema or maybe pneumothorax sort of a thing. Okay, this problem is emphysema or pneumothorax. I think this much is sufficient for you to know, right? Let me go forward to the next question. Simple question asked. A newborn baby is admitted in the ICU in a typical INI-CET question. Patient has to be given injectable antibiotics. Which of the following option is correct regarding requirements for intravenous cannulation in the newborn? Just waiting for how the answers that you people give. Then we'll go forward. Okay, guys. So what do you think is the answer? Dr. Rahul. Dr. Rahul, Dr. Srikanth have said B. So let's see. The baby is in the NICU. Injectable drug dena hai. Which of the option is correct? What is needed? The baby is a NICU. The baby, NICU means a neonate. Neonate means up to 6 months of age, if I'm not mistaken, or maybe 1 to 6 months. Maybe let's take like this: 1 to 3 months. Okay, neonate. 3 months mein you will use a small cannula. You will not use a 22 gauge. This is used for pediatric patients or young adults. I will prefer to use this yellow color or a purple color cannula. Okay, so therefore in the NICU, so whichever baby is there, 24 can be used. 5 ml syringe. Will you use it? Yes, to take the IV cannula. Normal saline? Yes, to confirm it. Adhesive tape? Yes, I will confirm it. Which is the correct option? Yes, most of you have marked it. It's B. Okay. Wherever it is 1, it is out, right? And only 2 and 5, just a cannula and adhesive shape. Yes, you can use it, but it's always better to confirm. Na? You will not want it to get blocked. So you will always take a syringe with saline, confirm your position and then put the adhesive tape. So the correct answer is B. Okay, simple question. The correct answer is B. Dr. Rahul says 1 month. Okay, ठीक है. Neonate is 1 month. Dr. Rahul correct. So 1 month बोला. 1 month. Okay. Basically admitted in NICU. 1 month. ठीक है. हमारे यहाँ ना NICU में 3 महीने तक बच्चे रह जाते हैं यार. My point is that when babies are there ना, they're kept for sometimes in 3 months also. Practical wrong experience. But you're right. The terminology is different. Huh? बचपन से मेरे को कंफ्यूजन था. Neonate, infant, pediatric, and child. Right from my college, no, right from my medical MBBS days, I never used to understand the difference between neonate, infant, pediatric, and child, and even today. Okay, it's the same thing. Confusing. Neonate, infant, pediatric, child. हाँ पता है. Neonate थोड़ा छोटा, infant थोड़ा बड़ा, pediatric और बड़ा, child और बड़ा. But where is the classification? That is the problem for me. Okay, right? Neonate, infant, pediatric, child. सब same है. मतलब if you have to arrange them in order, sequential order. I know the sequential order. Neonate comes like this, infant comes like this, pediatric would come like this, child would come like this. INI-CET. Okay. But इसके आगे मेरे को terminology है bad. ठीक है, let's go forward. Next question. Okay. So mark these answers and then we'll discuss it out. So chalo fast. I will have to take 10 minutes more here to finish off. Jaldi. I want to finish off this point. Okay. Because there are questions here, I want to discuss all of them. A patient after road traffic accident was attended by the paramedical staff, transferred to accident and emergency with the adjoining intravenous cannula shown in the image. Right? What is the flow rate of the fluid? Okay, that this cannula can deliver. So 66, 86, 96, 106. Right? So please mark your answers. I'll wait. The correct answer is, according to me, 86. I will go for 86. Yes, a lot of people would say, so these are all the questions which have come before also. Some people would say 96 or 106 also. So 106 is totally out. 66 is again out. The correct answer and confusion would be between 86 and 96. Now, this also depends on the make of the IV. There are different companies which make it. But remember, anything between 80 to 90 or 95 is almost, considered to be the flow rate for this kind of cannula. नहीं D नहीं है ना डॉक्टर श्रीकांत no Dr. Shivam, D nahi hai. I'm telling you the answer. It is B. I'll discuss this point again. Wait. What is the gauge? First decide. Then we'll discuss this point. There's 3 questions on IV cannula. Let's take all of them. The gauge. The patient of RTA attended by the paramedical staff transferred to accident emergency with adjoining intravenous cannula. What is the gauge? So the gauge is which one? This is what? Is it 22? It is 20, 14, 18 or 22? Dr. Shrikant, let me discuss the numbers. Dr. Shrikant, just wait. Let me just discuss after a while. I'll discuss your doubts. The next one is C. Dr. Nithya says. Correct. 18 gauge. This is what is called 18 gauge, and yes, it is wide bore. I agree. This then becomes which one? Correct. I'm not discussing. You know the answer. That was 18. So this is not 18. 18 is out. So this is pink colored one. This is 20. Right. Remember when we talk of the gauge, right, and when we speak of the cannula, so there is one in the center, the pink colored one, which is the most commonly used, right? Then there is blue, then there is yellow, and there is purple, right? On the other side, you get green, you get gray, you get orange. Of course, there is something called as white also, but that's how I kind of remember. These are the small ones. These are the wide bore ones, bigger ones. Okay. So the pink is the most commonly used. That's why it is 20. Here we get 22. This is 24. This is 26. Green is 18. This is 16. This is 14. Right. Okay. So the point is, this is the most commonly used in adults. This is used in normally pediatric, or it can be used in adults if you don't get the weight in the vein. This 24 is used in pediatrics and neonates. 26 is used in neonates and preterm neonates. Okay, this is wide bore. This is normally used for resuscitation, blood transfusion. Okay, this is used for resuscitation to give lots of fluids, or if you're giving blood to the patient, right? Flow rate now becomes important. So now you remember it. It has become a very common mnemonic to remember it as, if it is a yellow sun, in the purple, what is called purple is the galaxy. In the purple galaxies, there is yellow sun, where there is blue sky, there is a pink flower with a green leaf, on the gray ground with orange lava. It's made by students only. It has become familiar, and it's a nice way to remember. Okay, even I came across someone, nothing is my own over here, right? Even I came across someone when some students pointed out to me. Otherwise, I didn't know it how to remember, but it's a very nice way to remember. Purple galaxy, in that you have a yellow sun, and there is a blue sky where you get a pink flower, okay, with green leaves, the gray soil, and orange is the flower. Flow rate. So as I said, pink is 54 to 60. Can be given 60 also. Yellow is 20 to 25. So remember, guys, remember the closest number. The most common 20, remember it as 50. ठीक है, बच्चे लोग में उसका half use होता है. So 24 के लिए remember it as 25. So this remember is 20. Then anything close, as you will see, this number is 80. So 80, 90. The next one you see after 50 is 80. So this becomes your green one. Then 180 is the gray, and 270 is your orange. So you can just go forward one na. 80, 180, 270. That's how you remember, right? So this is the exact way in different things have been given. A lot of it also material. Some places this is given as 86, some places given at 92, some places given at 96 also. It's never 100. Yes, confusion between 86, 92, 96 will be there, but I normally would go to the big closest number close to 80. And what is given to us here is the image before this was, which is this one. Here is 86. As you can see, as I told you, I will be going with 86, but 96 is also very close by. It's not far away. Okay. So that is how we remember it. And I have discussed with you the flow rates also and the gauge also. Next question. So a specific complication that can be seen with the following procedure. Again, INI-CET, so controversial question. Guys, I'll take the class till about 10:15. I'll take about 15 minutes more, 15-20 minutes. Chalega na? Teja Sai says, Dr. Teja says, why in a patient when anesthesia given by lumbar puncture, CSF dispersed down? Arey, Dr. Teja Sai, ye to basic hai na? Okay. By the time other people are giving me the answer, let me discuss with. Okay, Dr. Teja Sai's question is very important. Dr. Teja Sai का question answer कर देता हूँ पहले. Dr. Teja Sai, when you are injecting lumbar, when you're doing lumbar puncture and you're giving local anesthesia drug, Dr. Teja Sai is saying it gets dispersed only down and does not go up. That is the exam question. Why? Because the local anesthesia drug contains dextrose. Dextrose is what makes it heavy. Because of being heavy, it settles down, it doesn't go up. That is exactly why the question comes regarding the specific gravity of CSF. Therefore, when we are giving the local anesthesia drug for spinal, it's not the normal local anesthesia drug. It is called hyperbaric drug. Hyperbaric drug means the specific gravity of the drug is more than the specific gravity of the CSF, and because of which the drug settles down. Thumbs up, Dr. Teja Sai. Clear? Then this question. Specific complications seen with the following procedure. Okay, coming back to the same question. So Dr. Mohit has said C, Dr. Teja Sai has said B, Dr. Shrikant has said D. B is the correct answer. When they have mentioned specific complication, guys, this is exactly why INI-CET is a different exam. I didn't say, of course it is difficult, but it is different exam. At times they ask you few things by rotation of words, right? So what happens is, the procedure being done here is a left-sided subclavian vein center line. Right? You're kind of, inserting a center line in the left-sided subclavian. So whether you put a center line in any vein, arterial puncture, remember, becomes one of the most important things that can happen. But on the left side, because the thoracic duct is going over here, you'll find the thoracic duct going over here, right? So this can puncture the thoracic duct leading to chylothorax, and that is why a specific complication commonly seen with a left-sided central line insertion, right, is chylothorax, right, on the subclavian vein. I'm not saying it can't happen on the right. Chylothorax, if you put a needle from here, can happen here also. From the right side subclavian also it can go here. But the chances in left subsided is much more than in the right side, which is what they might have asked in the exam. That's a specific complication. But if the word changes, right, and the word changes, what is the most common or immediate complication seen with following procedure? Same thing. In that case, chylothorax is not an immediate complication. Of course, it might take place, but more commonly, the most common is arterial puncture, because you've seen vein, artery, and nerve are together, right? So next to the vein, there's an artery. You can straight away cause an arterial puncture before going to the thoracic duct. Therefore, arterial puncture becomes the most common that you will see. Chylothorax, yes, it can occur. Thrombophlebitis, yes, it can occur. Empyema, no, I don't think so. Empyema means collection of the pus. If you go through according to chest. So according to me, empyema would not be correct answer for both of them. But thrombophlebitis, yes, it can take place later on. Yeah, vein inflammation will be later on, not immediate, right? So therefore, immediate can be again both things, arterial and chylothorax. But out of that also, arterial puncture is the most common and immediate. And if there's a specific complication, it is chylothorax. Clear? So let's go forward to the next one. Okay, so you find a patient lying unconscious while jogging. So I'll discuss 3 questions from here fast. And then I'll discuss CPR with you. And then we'll take another 3-4 small questions. I should be finished by 10:15. Okay. You find a patient lying unconscious while jogging in the morning. What would you like to do? Okay. Sorry. Please mark your answers. Then I'll discuss the next question and I'll take all of them together. Dr. Life in a good moment has given some options. No, he has given some good, nice feedback of emojis. Dr. Mohit and Dr. Rahul have given an answer B. Okay, so you have found a patient unconscious while jogging in the morning. What would you do? So, for that, we need to know the sequence, right? Sequence. First check pulse, then start CPR, then call for help. Wrong. Call for help will be first. Observe and wait. No. Defibrillate, check pulse. No. So basically, your confusion has to be between A and B. Correct answer is B. Okay, as Dr. Mohit and Dr. Rahul have said, correct. It is B. I'll discuss all the points, but let me take the 3 questions first. Dr. Nithya also says B. Correct. Next question देख लेते हैं. Typical INI-CET question, and I'll discuss all the points together. A person was found collapsed roadside, brought to the casualty by auto driver. You are the doctor on duty. Arrange the steps of CPR in the sequence that you would follow. Okay, so read it properly. As I said, these are the questions which have been asked in exam. And last 4 or 5 papers become the most important. I'm discussing all of them from anesthesia, and that's why it is your anesthesia revision. If you must have seen, I have not paid attention or discussed so much about the drugs. Yes, there may be drugs which can be there, but I'm discussing more questions on which they have paid attention to on the last 5 papers. Okay. Mark your answers, guys. Guys, remind me, I've got about 15 minutes of the class left, but before I close the PPT, tell me to save it. Only then you can get the written one, the one that I've written, because last time na मेरे से miss हो गया था. Okay, so now Dr. Nithya, Dr. Mohit have given an answer B. Dr. Shrikant says C. Dr. Nithya has given now C. Let me think. सबसे पहले check for pulse. From what we have, assess response. This should be the first one, right? Then comes check for pulse, correct, and breath, both together, correct. But the point is, auscultate for breath sound. No, you just are not supposed to auscultate over there. Breath sounds means you're supposed to look whether the patient is breathing or not. That's what is said in CPR. In the guidelines, they have not said auscultate, right? Chest compression would start after that. Bag mask ventilation after that. And in case left, then 5th will come over there. So this would then become 5th point, or if not, this is not an important point during CPR, otherwise 5th one. So I will go with 3, answer C. Thumbs up, everyone. As Dr. Shrikant and Dr. Nithya have said, absolutely correct. Okay, so in the steps of CPR, I will go with this answer. If it was written, check pulse and check breath. In that case, it was confusing. And then in that case, both pulse and breath would be coming the second point. But if they mentioned auscultate or auscultate for breath sound, वो तो last में चला गया. Breath sound नहीं करना है. You're just supposed to look at the breath, look at the visible chest rise, right? That was the point. Next question, and I'll discuss all of the CPR part after this. Okay. So these are the typical questions of CPR which they've asked recently. Effective CPR. Okay, effective CPR. Yes, guys, answer. I wait for the answer. I know session थोड़ा लंबा हो जाता है, but I like to look at your answers that you're giving me. Dr. Rahul Sharma has said C. Okay. Dr. Tejas Sai has said C. Correct. So Dr. Rahul Sharma and Dr. Tejas Sai have said C. So chest compression, is it 100 to 120 per minute? Yes. Do you allow chest recoil? Yes. Chest compression 5 to 6 per minute? Yes. Is respiratory rate 20? No. Respiratory rate, even if you're giving, has to be 12 breaths per minute. right? 12. Normally what you do is 12. Even if you intubate the patient, after intubation you are giving 12 breaths per minute. So therefore this is not correct. So therefore anything with A is out, and the correct answer is C. Correct answer is C. ठीक है, correct answer C बन गया. Did you understand the reason? Because respiratory rate when you're doing a CPR is not 12. I'll discuss all of them now. Wait. So when you talk of CPR, these are the guidelines, right? Remember in the guidelines when we go by steps. So let me show here only what is the steps. The first step is always scene safety. The scene safety is the first step, guys. Remember, even before call for help. So scene safety is the first step. The next step becomes check the response of the patient, right? Because the patient is collapsed, there is no response. And that's exactly the third step becomes call for help. So remember this order, the order that we are discussing, guys. Okay. The first thing that we discussed was scene safety. After the scene safety, you checked for the response. After the response, you checked, you call for help. So once you call for help, guys, what happens? You are calling someone so that they can get automated defibrillator, they can get the emergency equipment and all. Till now, you have not checked for breath and pulse. Once you call for help, guys, after that you're supposed to check for breath and pulse. After this, then you're supposed to check for breath, and then you're supposed to check for pulse. Remember, both are checked simultaneously. Okay, together. And you are supposed to check the breath and pulse within 10 seconds. Carotid is the pulse which is checked, and breath, you look at the visible chest rise. You don't auscultate. It is said visible chest rise, right? And you always check the carotid. In pediatric patient, you will check the brachial or the femoral. Once you check the breath and pulse, if there is breath and pulse both present, this is NEET PG question. So once you were looking at the breath and pulse in 10 seconds, remember, you're looking for breath, you're looking at pulse simultaneously. Yeah? The next step after call for help is check for breath, check for pulse together within 10 seconds. If there is if there is breath and pulse both present, you keep the patient in recovery position. This was the question of NEET PG. If breath and pulse both are present, you keep the patient in this recovery position. This is what is called recovery position, right? And here you'll just observe the patient. This was the question from NEET PG. This question was asked. Okay. So if both the pulse and breath are present, you will keep in recovery position. Now, if the breath is not there and the pulse is not there, then you are supposed to start the CPR. Okay. If the pulse and breath both are present, you are not supposed to do anything. If it is yes, pulse is yes, you just keep the patient in recovery position. You start the CPR if there is no breath and if there is no pulse, then I start the CPR. And nowadays the CPR is done chest compression, airway and breathing, right? So chest compression is normally lower 1/3 of the sternum. Okay. Here what you will do is you are giving 100 to 120 chest compressions per minute, right? You are allowing the chest recoil to take place. All right, and the depth is 5 to 6 centimeter or 2 inches to 2.4 inches. This is the chest compression. When you give a breath, remember here you have to airway. So this was chest compression. A is for airway. You have to open up the airway and make it patent. So for that you do head tilt, chin lift, jaw thrust. This was the next question of NEET PG this time. This was the question, head tilt, chin lift. This is head tilt, chin lift. This was the question asked. You have to open the airway, right? So after open the airway, you're doing head tilt, chin lift. Head tilt, chin lift, jaw thrust. Right? This is what is done. Open up the airway, and once the airway is open, then you will give the breath. Right? Then you start giving breath to the patient, which is B, chest compression, airway, breathing. Dr. Mohit says recovery position in name. No, Dr. Mohit, according to me, it's called recovery position only. If there's any name, I am not aware. Okay. When you give a breath to the patient, remember you always give 2 breaths at one time. Inspiration over 1 second, expiration over 1 second. And when you give a breath, always look for the chest rise. So once you've given inspiration, look for the chest rise. Allow 1 second for expiration. Don't do excessive ventilation. That is how you give a breath. And breath can be given mouth to mask, bag mask. Best is the bag mask with oxygen. Right? And once you get a defibrillator, you have to incorporate the defibrillator into it, right? With CAB, you will, once the defibrillator comes, then you attach the defibrillator and you check for the rhythm, right? CPR is going on, but then you immediately check the rhythm. So now if the rhythm of the patient, sorry guys, now if the rhythm of the patient, once you get a defibrillator, guys, remember, once you get a defibrillator, the dying rhythms can be two types. It can be something like this, which is ventricular tachycardia, or it can be ventricular fibrillation like this, or it can be pulseless electrical activity or asystole. So if you get the dying rhythm as ventricular tachycardia or ventricular fibrillation, you are supposed to give a shock. Monophasic defibrillator 360, biphasic defibrillator 120 to 200 joules. Shock. After that, do not do a pulse check. Straight away start CPR, right? The way that we have discussed with you, 5 cycles, 30:2 in 2 minutes is what is done, right? 5 cycles, 30:2 in 2 minutes, the same CAB that we were doing, right? You continue the CPR. After that, you check for the pulse. If there is no pulse, again you look at the defibrillator, right? You have to keep on checking. And if it is asystole or pulseless electrical activity, you cannot do anything. If you're on the road, don't do pulse check, start your CPR, and after the 2 minutes of CPR that you're doing, 2 minutes, 5 cycles, which you're doing, after that, check for the pulse. If there is no pulse, again check for the rhythm. This is exactly what is done for 30 to 40 minutes, and then you declare the patient dead. Thumbs up everyone, that was CPR, pura CPR. Huh? BLS, I've discussed with you basic life support. Right? That's exactly what they've said. And in case you're in hospital and by chance you get adrenaline, here you can use adrenaline also, which can be given every 3 to 5 minutes. Remember, 1:10,000 we discussed. Every 3 to 5 minutes. ADR can be given. So this is your BLS. The difference between ACLS is that here you have taken, it becomes ABCD. A means airway secured, endotracheal tube or laryngeal mask airway. B means you are giving a breath from the endotracheal tube now. From the endotracheal tube, you will be giving 12 breaths per minute. You are not giving 24 breaths per minute. C means now you have taken circulation. You have an IV access, or last year NEET PG question, intraosseous access. Can you see this was a question asked last time, NEET PG, intraosseous. This was the question in NEET PG. So IV access or intraosseous access is available. So therefore you can start giving your drugs. Adrenaline can be given. You can use amiodarone and lignocaine, 3 drugs which are used. And D means you keep on trying to discuss what are the differential diagnosis, 5H and 5T. The same thing, hypovolemia, hypoxia, hypokalemia, you'll keep on thinking that. So this becomes your ACLS in short. ACLS means airway secured, you are keeping on giving the breaths, you have an IV access, and you keep on thinking of differential diagnosis. This is complete BLS and ACLS in short. Thumbs up guys, is it clear? All of you? CPR पूरा डिस्कस कर लिया मैंने, because CPR important है. Yes guys. Jaldi. So we are done with the CPR. We have again 3-4 questions I think which are left, and I want to finish them also. Why to leave any question here? Yes guys, all okay everyone? Can I go forward? किसी का मैसेज आया नहीं. Are you there? You people are there? Yes. So kindly identify the device in the image. So next 3-4 questions are simple questions. BLS में difference. Dr. Mohit is asking difference. That's what I wanted. BLS में difference about what? Okay, BLS and ACLS में difference. Okay. So what is the difference between? Dr. Sahu Patil says Durant position. नहीं, I don't know whether it's called Durant position or not. I'm not sure. जो मेरे को नहीं पता है, कोई point नहीं है for me to tell you. I don't think so. I don't know about the Durant position. You people would be knowing it better than me. I don't know this point. Dr. Sahu Patil. Now, Dr. Mohit has asked me regarding. Dr. Teja, just 1 second. Dr. Teja Sai and Dr. Srikanth, 1 second. Dr. Mohit had asked me difference between BLS and ACLS. BLS and ACLS. So remember, BLS means basic life support, which can be done anywhere. It can be done to a passerby on road. This is basically you have no equipment. There will be no one to help you. So basically, whatever maneuvers you're doing on the street is what is BLS. You can do in the hospital also. ACLS means it becomes advanced. It means now you have got equipment. It means now you've got people to help you. Someone else can take a charge, and you're doing it normally in a hospital or of course in a van where there is medical facility available. So the difference between BLS and ACLS is that this is more of roadside or anything how to intervene and save someone's life. ACLS means now there are people to help you, there is equipment, and in a hospital or medical facility is what you're doing, right? Then hopefully that point is clear, Dr. Mohit, but that will not be asked in the exam. So ACLS becomes more advanced. It's called advanced cardiac life support. This is basic life support. Let's not go into details about that. Here, let's me, Dr. Tejas has given the answer B. Dr. Shrikant has said A. The guys, the correct answer is B. This was asked maximum at a time when COVID was still going on and the image was asked. This is high flow nasal cannula. This high flow nasal cannula, this is what can give up to 100% oxygen, and you use almost 50 to 60 liters of the flow rate of oxygen. That is why it looks like a small ventilator. Okay, without a monitor. It's a CPAP machine? No. A CPAP machine basically consists of a mask on the face. Patient will be having a mask. That mask which is there, na? The CPAP machine will having a mask which will be tied over to the face of the patient. That would be CPAP. Okay, so this is not a CPAP machine. Ventilator will have an endotracheal tube inside, right? Ultrasonic nebulizer will have a normal mask, nebulizer mask. Okay, so ultrasonic nebulizer will have a normal face mask from which you will nebulize the patient. Ventilator will have normally have an endotracheal tube or a laryngeal mask. More than LMA, it will be endotracheal tube. CPAP machine will have a mask which fits into the face. And this is just a nasal cannula which is lying over here. Okay, so this is that device. This is high flow nasal cannula, and I think most of you have given me the correct answer, right? Since we are discussing ventilators, remember questions on ventilators have been asked in INI-CET. This is one of them. If you don't understand, it's okay, but I'll just try to discuss in short. Okay, just in short, I'm not going to go into too much details of ventilator, but just in short. So in ICU, please mark your answers and I'll discuss. A ARDS patient is on ventilatory support. The weight of the patient is 60 kg. The ventilator settings are tidal volume 360. I is to E ratio, which is inspiration to expiration ratio, 1:2. FiO2 is 90, means how much oxygen. PEEP is 5. ABG is collected. It shows the reading of pH 7.38, PaO2 of 50, and PCO2 of 35. Okay, so what will you do? Will you change the IE ratio to 1:3? Will you increase the tidal volume from 360? Okay, will you increase the PEEP from 5, or will you increase the FiO2? This is the question asked. Yes, guys? Anyone? As I said, sometimes if you don't know question like this and if you have to leave it, just leave it. Right, in the exam if it comes. Don't waste your time thinking about a question on a topic which you might not know so much about. So questions like this come, if you understand it, well and good. But in exam, right, Dr. Shahu Patil is saying A. Dr. Mohit says C. Anyone else? Right, Dr. Shahu, that's what I'm saying. अगर INI-CET के एग्जाम में बैठ रहे हो, तो अगर जहाँ पे नेगेटिव मार्किंग है and one point is important, so this is one question that you don't know the answer, you can just leave it, right? But the correct answer, as Dr. Mohit says, is right. Increase the PEEP. Absolutely correct. Okay. So what is the point and what am I discussing now? Remember, it's a ARDS patient. ARDS मतलब, अगर just let's go to basic. ARDS का मतलब होता है baby lungs, right? Baby lung का मतलब होता है कि if you put any pressure, lung फट जाएगा, right? Right, Dr. Anytime Dr. Arrhythmic Doc, or one more nice name, Dr. Arrhythmic Doc has also said C. So ARDS means baby lungs, which means baby का, not baby lung, but the patient का जो lung है वो फट जाएगा if you giving more pressure. So you can't give a lot of pressure to the patient. You can't give a lot of tidal volume where thak, burst ho jaye. In fact, that is why we use a mode called pressure control mode. Let me not go into the modes of ventilation now. So normally ARDS may we don't use a volume control mode. This is what is about volume control. Many times we use pressure control mode also, right? Because the lungs are almost damaged. You don't want barotrauma to take place. So therefore, you ventilate the patient by a strategy which is called as low tidal volume. Okay, normal tidal volume people would say 6 to 8 ml per kg. So here you will try to give less tidal volume. 4 to 6 almost will be okay. 8 to 10 is considered normal. यहाँ पे 4 to 6 low tidal volume is okay. So 60 kg weight के हिसाब से, okay, so 60 into 6 is 360. According to that, it is fine. Ideally, the patient of 60 kg into 10 should be getting 600 ml of tidal volume, right? But we are giving only 360, मतलब 60 into 6 हो गया, which means it is low tidal volume, which is fine. Ice to E ratio. So first, let's look at the ABG. pH of the patient is normal. You don't have to do anything. PCO2 of the patient is normal. You don't have to do anything. Problem is oxygenation, which means you have to give oxygen to the patient. So out of the methods given to you, which is the one जो patient को oxygen बढ़ाएगा? If you increase the I/E ratio to 1:3, it means inspiration is 1 second, expiration is 3 seconds, which means CO2 will further wash out, which means PCO2 will decrease. Do I want that? No. So this question is out. Because if you change I/E ratio, which means expiration will be more. Do you want expiration? Because carbon dioxide to theek hai, out. You will not use it. Do you increase the tidal volume? Yes, I can try because low tidal volume hai. But remember, ARDS patient hai. So this is also out. Right? If you don't know anything, I'm just telling you how can you derive to this question. So changing I/E ratio is not going to change the oxygen of the patient. Increasing tidal volume, yes, it can increase the oxygen to a patient to a certain extent, but ARDS patient may I will avoid it. So this is out. Increasing PEEP, will it help? Because PEEP is only 5. Yes, this is one of the strategies. Increasing FiO2, it's already at 90%. How can you make it, even if you make it 100%, it can cause damage. Remember, FiO2 should be decreased as early as possible to as much as possible. So therefore, there is something called as ARDS net protocol. I'm not going to go into those details at all, but in just to tell you in short, what does this protocol tell you? You have to combine FiO2 and PEEP in such a manner where both are, the aim would be maintaining the oxygenation between 55 to 80, saturation of 88 to 95. So the point is, ARDS patient may this becomes the goal. Somehow or the other, don't let it be 50. Try to achieve a PaO2 of 55 to 80. Whatever helps you. In that case, they say you can use a combination of PEEP. You can use high PEEP and low FiO2, which can be done. I'm not discussing anything regarding plateau pressure. I'm not discussing anything regarding ventilator setup. Let's not go into all those details. I'm just discussing in short what can be done. So I would rather say you can use a PEEP. A PEEP can be increased. And can you see you started with 5 PEEP and you've gone up to 16. It is increasing even more, right? So you can increase PEEP. PEEP is positive end expiratory pressure. It prevents the collapse of the alveoli basically for more oxygenation. So therefore, rather than increasing the FiO2, which is already 90%, which will not help me much, I will increase PEEP. And PEEP is positive end expiratory pressure. Thumbs up everyone, clear? I'm not going to go into too much details of ventilator as I said. Okay, last moment where one should not be reading so many new concepts. How much ever you know is okay, but hopefully this much has come across to you. Okay, matlab at times don't go too much into detail of the topic right now. It is just a revision. ऊपर से देख लिया. That's it. You have understood what is PEEP. You have understood how to increase oxygen or how to look at this answer. Okay. The point is, even if you don't know, just remember patient का pH normal. You don't have to do anything. PCO2 normal. You don't have to do anything. Somehow the other increase oxygen. How will you increase oxygen? By IE ratio? No, you can't do that. By increasing tidal volume, ARDS patient will not do it. By increase FiO2, it is already 90. Maximum you can do is 100. Basically is increase PEEP. Thumbs up everyone. Clear? Right? Dr. Mohit says give me thumbs up. Let's next question. Simple questions now. Another 3 questions. Just 3 questions are there, I think. Only 3. Let me finish off now. It's no point, shutting it down in between. Just 3 questions. Ventilative support is required if SpO2 becomes less than 90 because simple question. Hai. Now, why did you think someone needs, ventilator support? SpO2 becomes less than 90, especially in those COVID patients. Why do you want? Yes, anyone? So the options are central chemoreceptors become insensitive to hypoxia below 90. Nah, not the answer. Peripheral chemoreceptors insensitive. No. Okay. Patient's capacity to generate adequate tidal volume. No. The most important point. Tissues become vulnerable to for hypoxia below 90%. For this answer, tissues become vulnerable, guys. Who remember this S-shaped hemoglobin curve? All of you remember this? S-shaped oxyhemoglobin curve, right? So you know at one level it is oxygenation, Pa2 is maintained, but all of a sudden it will then fall down, which will lead to complications. Okay, so that's the point. Just remember S-shaped oxyhemoglobin curve, and tissues will become more vulnerable for hypoxia. Immediately hypoxia can set in. So the answer is C. Tissues become vulnerable. That's exactly why you need to give oxygen. Na? Why you think ARDS patient में यहाँ पे we are worried? Why you want the PaO2 to increase? Why you want to give oxygen? So that the tissues को problem नहीं हो. So that the tissues will be vulnerable. The whole point of this ARDS protocol is that you have to maintain oxygenation so that the tissues get oxygen, because if your tissues don't get oxygen, patient will be dead. That is the whole concept of ICU management. ICU में हम लोग करते क्या है? ऑक्सीजन देना है, कार्बन डाइऑक्साइड बाहर निकालना है, यूरिन बाहर निकालना है. That's it. If you have to discuss ICU in 3 words, I'll say just one thing is done in ICU. Give oxygen, take out carbon dioxide, and take out urine. 3 things. That's the only thing that you do in ICU. Okay? No, other things are also done. That is in short what is done in ICU. Right? So tissues become vulnerable. Now, since COVID is there, this question becomes all the more important. 30-year-old patient just recovered from COVID. Okay? He had symptoms in home isolation, treatment, but needed no hospitalization. He is to undergo hernia surgery, which means elective surgery. Hernia repair is elective. It is not emergency obstructed hernia. So for how long an elective surgery should be deferred in the patient? So next question. Okay. These guys. Just waiting. Anyone with the answer? Okay, so let me give the answer. The correct answer here is Dr. Shrikant says B. Correct. Absolutely correct. B. So you just need to know this point. They have said if there is, this is the old time guidelines. I'm not talking of the newer guidelines. कुछ ऐसा निकला नहीं है, but this is from the American Society of Anesthesiologists when COVID was rampant. जब बहुत सारा COVID था, ये तब की बात है. So they had said that if the patient is asymptomatic patient and someone who has got a mild symptom, only 4 weeks are sufficient. But if someone is symptomatic but no hospitalization, 6 weeks, this is what was asked. But someone who is asymptomatic or diabetic immunocompromised or someone who is hospitalized, means hospitalized with symptoms, that is 8 to 10 weeks, and in ICU it is 12 weeks. Okay. So the correct answer, Dr. Mohit, the correct answer is B. So if you have to just shorten it out, remember 4 weeks if there is no hospitalization, symptoms and no hospitalization 6 weeks, symptoms and hospitalized 8 to 10 weeks, and ICU is 12 weeks so that the patient can recover. Okay, so just remember like this. If the patient had asymptomatic or just mild, no hospital, in this case 4 weeks. If the patient is symptomatic and no hospital, in this case 6 weeks. If the patient is symptomatic, is diabetic, comorbid, and hospitalization, dono, in this case it is 8 to 10 weeks. And if the patient was in ICU, 12 weeks. Okay, that's the answer. So our correct answer is 6 weeks that we have seen. Okay, 6 weeks. Next question. 60-year-old male patient undergoing lap cholecystectomy. During surgery, it was observed sudden decrease in EtCO2, saturation 90, BP decreased, and peak airway pressure is 80. Which of the following is the most probable? So, is it only one, which is carbon dioxide embolism? Is it only two, pneumothorax? Or both 1 and 2? Or both 3 and 4, endobronchial or bronchospasm? This was again INI-CET question. Yes, so let me give the answer then. I was waiting from your side, but let me give the answer. CO2 embolism, pneumothorax, endobronchial, and bronchospasm. So out of this, what are the points? EtCO2 has decreased, SpO2 has decreased, BP also has decreased, but peak airway pressure, correct? Dr. Tejasai has given A, and but Dr. Shrikant has said D. D नहीं है, A है. Okay, it is carbon dioxide embolism. Why not other answers according to me? See, CO2 embolism, if you remember capnography, I just discussed with you. In capnography, I discussed with you that CO2 ka graph becomes like this. Remember? No carbon dioxide coming out. I discussed with you this is what happens in embolism. After a while, there will be no CO2 coming. Embolus will block it. Right? And this is also going to decrease the BP of the patient, and there will be sudden decrease in SpO2 that is taking place. So all the three things are seen. In embolism, there is nothing to do with peak airway pressure because endotracheal tube is normal. Right? So endotracheal tube is normal. So if I have to see, if it was endobronchial intubation in the bronchus, this airway pressure might have changed. Possible. Right? But that will not cause so much change in EtCO2. Okay, it can cause a decrease in BP and SpO2, that I still agree. But endobronchial intubation, it means tube in the bronchus, is not going to decrease EtCO2. No, that's not the way. Bronchospasm, remember carbon dioxide graph was like this. But it is coming, it's not going to decrease. Remember, EtCO2 is almost like PCO2. The normal value is 35 to 45. EtCO2 8 means it's absolutely zero, no EtCO2. So patient extubation can be one thing, but endobronchial intubation is out. Bronchospasm is out. Pneumothorax, one might think. But pneumothorax, guys, on the contrary, remember I told you pneumothorax emphysema will produce a graph like this. Normally means EtCO2 is coming, but this becomes slightly different. That is what is seen in pneumothorax, not so low. Okay, and pneumothorax will not have a peak pressure which is 18. This will increase considerably. It's pneumothorax. Carbon dioxide CO2 embolism is the only thing because laparoscopy cholecystectomy has been given. According to me, the correct answer is CO2 embolism. Clear? It finishes off this question also. So what happens in laparoscopy, guys? We are giving this, it's insufflated with carbon dioxide. So because of insufflation, sometimes what happens when you're injecting the various needle, na, तो यहाँ पे जाके carbon dioxide, or when you're trying to do a puncture, CO2 goes here, thak, यहाँ पे जाएगा, it causes CO2 embolism. We are putting the gas inside, it can straight away cause CO2 embolism. Right? That is the reason why CO2 embolism is so common. It is, it's a dreaded complication of laparoscopy. Next question. Again, simple question. What will be the MET equivalent of 1500 ml of oxygen consumption for a healthy 70-year-old adult male with basal oxygen consumption of 250 ml per minute? 2, 4, 6, and 10. If there are any doubts, guys, you ask me. So these are all the questions which have been asked in the last 5 years. I've revised all of them. Huh? Let me see. After this, I think there's just two questions more. After this, two more questions. Then we are done. Yes. This is a simple question. MET is metabolic equivalent. Metabolic equivalent. So what will be the metabolic equivalent of 1500 ml of oxygen consumption per minute for a healthy 70 kg male with basal oxygen consumption of 250? Which means the basal consumption is 250 ml per minute and he is consuming 1500. So 1500 is what he is consuming and his basal is 250. So they are asking you what is MET. So divide it by 250. This becomes 6. The correct answer is C. Absolutely correct. Absolutely correct, Dr. Mohit. It is C. Even if you see, remember basic metabolic equivalent is for a resting person, patient at rest, is 3.5 ml per kg per minute. 3.5 ml kg per minute. So according to that, if you will go, so 70 into 3.5 will almost be the same things, 240 to 250 ml, which means it's correct. So 70 kg male, when he's at rest, he's consuming 250 ml per minute. So if he's exercising, he's consuming 1500. So his METs is 6. Why am I discussing? Why is it important? METs basically tells you cardiac function. Under anesthesia, I don't know anything about a patient. I have to give general anesthesia. How will I come to the patient is fit or unfit? In a pre-anesthetic checkup, PAC, I'll ask the patient, can you do a strenuous sports like basketball? He'll say, yes, I play basketball, I play tennis. His METs is 10. He's fit to undergo anesthesia without even testing for cardiac function. If someone says, yes, I do cycling, I do dancing, which means METs is 6, he can undergo general anesthesia. Someone climbing a flight of stairs, walking up a hill, this person can undergo general anesthesia. Walking on a level ground at 4, light household work, he can give general anesthesia. But if it becomes less than 4, someone tells me, sir, I can't climb more than few stairs, I can't run, I can't walk on level ground for some time, it means the patient's cardiac tolerance is less, and in this patient I will get further investigated, so therefore metabolic equivalent basically tells me about the functional reserve or the cardiorespiratory function of the patient, basically the cardiac respiratory function. We can take the patient for G or not. Less than 4, I will try to investigate the patient further. More than 4, patient can undergo general anesthesia safely. But less than 4 is a problem. Less than 4 means he cannot do any, it means basically this patient has a sedentary lifestyle. He can't do anything else. He can't do light work also. Patient with moderate and vigorous work can undergo anesthesia. They have good cardiorespiratory reserve. Okay, so that's the point behind it. It's done in PAC. Simple question next. As I said, ideal measurement of nasogastric tube from where to where? From where to where? Angle of mouth to below the ear, correct? Till Ziphy sternum, or tip of the nose to below the ear or till manubrium, right? Or tip of the nose to ear lobule to midpoint of manubrium and umbilicus, and tip of the nose to below the ear lobule till umbilicus. This was asked in the exam. Ideal measurement of nasogastric tube. So this can be a common question between medicine, pediatrics, surgery, anesthesia. That's how question comes in the exam, right? Yes, anyone? So according to me, angle of the mouth to below the Ziphy sternum. Ziphy sternum is here. No. Manubrium sterni. No. From the tip of the nose to the midpoint of manubrium and umbilicus. Yes, that is the correct answer. Right, Dr. Shrikant? Correct. C is the correct answer. Okay. So if you will see the diagram also, this is exactly what it has to go. The tip of the nasogastric tube. So what will you do? You will take from the nose to the ear lobule, and if this is the manubrium, so a line between the umbilicus and the midpoint of that. This what is done. See, can you see? From the tip of the nose to ear lobule and the midpoint between this midpoint. So this is the length of the nasogastric tube. Hopefully the point is correct. Dr. Tejas Sai also says C. Correct. Last question. Kindly identify the surgical positions shown in the image. This is the last question. This covers anesthesia questions, few from surgery also, and common questions between anesthesia and surgery. I think I've discussed all of them. Last 5 papers, all INI-CET. Without trying to miss out. Hopefully. This is the last question. Anyone? Just waiting for the answers, right? Jackknife, lithotomy, Trendelenburg, reverse Trendelenburg. Dr. Akhil Kumar is given the answer. Correct. This is reverse Trendelenburg. Absolutely correct. Remember, sometimes these questions are asked. Dr. Tejas Sai said C. No, Dr. Tejas Sai, C. Trendle, oh, नहीं उल्टा उल्टा, sorry, my fault. Trendelenburg, okay, my fault. Dr. Tejasai, you're right. Dr. Akhil, sorry. See, Trendelenburg is this. Reverse Trendelenburg is when the patient is put this way, right? So when you are doing laparoscopy, this is the position which is normally done for a laparoscopic gynecological surgery. When you are doing laparoscopy like gallbladder, this is what is done like Trendelenburg position, the one which we had seen, sort of, right? So in exam, the most important point, just remember there are 3 or 4 of them, okay, which is your supine, prone, Trendelenburg and reverse Trendelenburg. These 4 are the most important positions which are asked in the exam. Okay guys, so supine position is this, Trendelenburg is this, reverse Trendelenburg is this, okay, and right, jackknife position normally they don't ask you, prone position is this. So they ask you about the injuries, your eyes may be injured, correct, endotracheal tube can come out. In Trendelenburg and reverse Trendelenburg, the problem is related to basically all the points related to that injury to vessels, embolism, carbon dioxide, laparoscopy. Both of them are used in laparoscopic positions. Okay, guys. Okay, according to me, na, I think this has been given wrong over here. Trendelenburg is basically niche, na. Trendelenburg. I think we'll just confirm it. यार एक बार surgery से भी देख लेना. But according to me, this is Trendelenburg and reverse when it goes down. नीचे. ठीक है, we'll just confirm it too. ठीक है, according to me it is C. I may be wrong also, guys. ठीक है. According to me it is C. Now, so I finished off anesthesia discussions, guys, completely. And this is again other sessions that have been planned. So all the subjects for INI-CET. Thank you everyone for joining me. I will save this right now once I'm finishing off the PPT. Remember, we have our grand test for INI-CET also. This is scheduled. Please try to appear in that, okay, so that you can check your preparation. And as I said, it's always better to give as many tests as you can, right, guys? You can join us. My Telegram ID is Dr. Vinish. You can connect me on that, Dr. Vinish. You can find someone with playing the guitar. No, someone teaching also. Either of that. That's my Telegram ID. You can connect me directly over there. Okay. So guys, any questions and doubts right now? Yes, Dr. Nithya, I'll save it. I'm saving it now. Thank you. Thank you for reminding me. I'm saving it and I'll be sharing this on the Telegram group. I hope you people are there on the Telegram group. So you will be getting this PDF. PDF from this will be put on the Telegram group tomorrow within 24 hours. Okay. Dr. Srikanth, I'm saving it. Okay, guys. That's my Telegram ID. So anyone who wants to get in touch with me, any questions or doubts, I'll try to solve them to the best of my knowledge. Yeah, Dr. Srikanth, I'm saving it. Dr. Nithya, I'm saving it. Right? Any questions and doubts, guys? Hopefully not. So thank you for joining me at this session. And I need to save it, as you people said. Correct. Do you want to keep? Yes. No. Keep. I'm keeping them. Hopefully they've got recorded. Yes. And I'll be sharing this with you in the form of PDF. Right? It has been recorded. I'll be sharing it. Thank you, guys. So thank you for joining me. Any questions and doubts, ask me. And I need to save it here as well. Save. All right. So thank you, everyone. Any questions and doubts? Dr. Akhil says Telegram group का name. वो इसी में दिया है Dr. Akhil. It's given there itself. Telegram का ना यहाँ पे link दिया है. It's given in the YouTube link. You can just join it over there. ठीक है. Dr. Srikanth, thank you. Dr. Akhil, thank you. Dr. Nithya, Dr. Mohit, Dr. Tejasai, Dr. Akhil. Lot of you were there. Thank you so much for joining on the session. Any questions and doubts, guys, you can ask me. Okay. Any questions or doubts? Okay. So hopefully then I'll take your leave, guys. Thank you so much for joining me. And as I said, remember, this is my Telegram ID is Dr. Vinish. Just remember. That's my Telegram ID. Okay. Thank you, guys. All the best to everyone. All the best. Do well. And remember, see, exams come and they go. The point is just to be happy. Okay. Try to just be happy. INI-CET, NEET PG, everything is important. Keep on giving the exams. Be always sure that you will do it. At the same time, just give time to yourself and always relax. Keep time for yourself also. Okay. Thank you, everyone. Good night. All the best. Thank you, Dr. Akhil. Thank you. Thank you, guys. Thank you. Thank you, everyone. Thank you, Dr. Akhil. That is so sweet of you to mention that. Thank you. Thank you. होपफुली तुम लोग का एनेस्थीसिया रिवीजन हो गया. डॉक्टर AKS Rajput is hi. Hi, Dr. AKS Rajput. Again doing anesthesia, Dr. AK. No, again doing NEET PG. No, INI-CET, Dr. AKS Rajput. अभी ज्वाइन किया. चलो यार. I hope no questions then. I hope no questions. चलो bye. Then I'll sign off. Thank you so much.